So we are starting in 3, 2, 1. Please start, ma'am. We are live.
Good evening and namaskar, everyone. I welcome you all on the second day of Current Oncology Update Series 4 SABCS Updates 2021. With immense pleasure, I would like to welcome Dr. Rajat Bajaj, who is Senior Consultant Medical Oncologist, Fortis Hospital, Noida, for his welcome and introductory note and to set the ball rolling. Over to you, sir, for the further proceedings.
Yes, sir. You can invite Dr. Vikas Talreja for first.
Okay. Right. Good evening, everyone. I welcome you to the day 2 of this SABCS 2021 updates. We had a very nice and interactive day 1 yesterday, where we spoke about a few of the updates which were presented in the recently concluded SABCS, and then we had a panel discussion to understand from our esteemed panelists as to how we should pave our way ahead in terms of treatment in the coming few years. In the treatment of breast cancer, and now with day 2 we are equally excited to discuss as to what should be the treatment paradigms in the management of breast cancer, and what are the key take homes from the recently concluded SABCS. So now to set the ball rolling, we have with us our first speaker, Dr. Vikas Talreja. Dr. Talreja, Department of Medical Oncology at Dr. Talreja is going to talk us through the RxPonder phase 3 randomized control trial, and the updates of this trial were presented in SABCS 2021. So what exactly has been the important message in this trial is what he's going to tell us. Dr. Talreja, over to you.
Thank you, Dr. Rajat. A very important meeting, and I must say that it must have been a difficult thing to organize such a meeting at such a short notice, just after the conclusion of the SABCS. It must have been a sleepless 2 weeks night for the last, and still I would say that it was a brilliantly conducted job and a very important trial. You have asked the opening batsman for the second day to
and I think you are talking from personal experience, because you also are undergoing the same thing.
I totally agree, and that's why I said that it must be very difficult, because you get a lots of information at your hands. You get a very limited time, and then you have to scrutinize and filter it out and give out the relevant messages to the audience. It is very important that we carefully select that agenda, because there is a lot of information bombardment, I must say, and that bomb we have to somehow channelize and give the right way to the direction. And that's why it is important that the agenda should be carefully selected, because at the end of the day, the relevant messages, the practice changing things, and what we say, the view from the trenches, that was beautifully discussed in the SABCS. We will be carrying forward the next week for the same torchlight with the relay race you have started. We will be doing it in the best of the abilities, but then again, congratulations and brilliantly job done, I must say. So we will be not wasting time. I know time is precious, and that's why we will be discussing a very important trial. That's the RxPonder trial. The RxPonder comes from basically the clinical trial RX, that is treatment for the positive node endocrine responsive breast cancers. It was a trial which was started a long way back, and the updated results from the phase 3 were presented with those who have 1 to 3 positive lymph nodes, hormone receptor positive, HER2 negative breast cancers with an oncotype recurrence score of 25 or less. That was the SWOG study S1007. Next slide, please. Next slide, please. So we go to the background of it. As we know, the 21 gene oncotype recurrence score in patients with hormone receptor positive, HER2 negative breast cancers, 1 to 3 positive lymph nodes has been here for a long time. And in the RxPonder trial, basically chemotherapy benefit was deferred by the menopausal status with the recurrence score of less than 25. So the post-menopausal, no chemotherapy benefit for the invasive disease-free survival or the distance-free survival. The pre-menopausal, the chemotherapy benefit was observed. And therefore, they reported the update in the invasive disease-free survival, disease recurrence-free, distance relapse-free survival. And the new analysis was done for the distant recurrence-free interval and the post-hoc analysis in the pre-menopausal women, which were around 33% of the RxPonder trial. Next slide, please. So RxPonders, the schema was all those women who were hormone positive, HER2 negative breast cancers with a low nodal disease burden, 1 to 3 lymph nodes positive without any distance metastasis, who were able to receive adjuvant chemotherapies, either taxanes and anthracycline based regimens, and an axillary staging by the sentinel lymph node biopsy or axillary lymph node staging. Now, the recurrence score of 0 to 25 or recurrence score of more than 25, that was the two limits. The more than 25 was somewhere we know that the chemotherapy benefit is there, but for less than 25, it has always been a caution. And that's why the randomization of nearly 5,000 patients were done. The arm A consists of chemotherapy followed by the endocrine therapy. The arm 2 consists of endocrine therapy alone. The stratification factors were based on the recurrence score. They further stratified between 0 to 13 and 14 to 25 menopausal state, whether pre or post-menopausal, and axillary surgery, whether the axillary lymph node dissection was done or only a sentinel lymph node biopsy was done. Next slide, please. Now, the statistical plan was basically the primary outcome was the invasive disease-free survival updated analysis with 553 events and a median follow-up of 6 years. Prior analysis with a median follow-up of around 5.3 years. Now, the distance recurrence-free interval was something which was newly added, where they included the loco-regional recurrences, the secondary invasive primary cancer, whether a new breast cancer was formulated in the follow-up study, or there was a death from a breast cancer on an unknown cause. Now, this includes a broader category, and it includes a very important, especially when you give chemotherapies, you have secondary mortalities due to various other causes. And that's where it is important that these formulations tend to play. Hello, good evening. Pharmacy में distribute कर देना, आपस में खा लो please. Hello.
Yes, please carry on.
Sorry, I accidentally muted myself. Next slide, please. Now, look at these curves. I might have to, my pointer doesn't come in between of these. You could see the hazard ratio, exactly unity in either of these in terms of the invasive disease-free survival and the distance relapse-free survival, showing that post-menopausal women don't have any chemotherapy benefit when you give them in a recurrence score of 25. So exactly crossing over each other, none. So whatever the results were in the prior and benefit of giving chemotherapies to the post-menopausal women. Next slide, please. Now, pre-menopausal women do have a chemotherapy benefit, as you could see those curves separating early and consistently separating till the end. And you could see that the 5-year absolute chemotherapy benefit was 5%, which was again 5%, as you could see from the same. And also the distance relapse-free survival benefit, you could see 2.5%, which was previously 3.3%. So there was a difference, and you could look at the hazard ratios. It was around 0.64, meaning a 36% reduced risk of uh, deaths and invasion and recurrences when you give chemotherapies to a premenopausal woman, where you would have thought that we could have obviated the chemotherapy with a low recurrence load of 25. Next slide, please. Now, again, if you look at post-menopausal women reference, where the new analysis of the distance relapse-free was taken into account, you see that the benefit isn't much there. Hazard ratio, again, 1.12. But look at in the premenopausal women, chemotherapy clearly outweighing the endocrine therapy by an absolute benefit margin of 2.4%. And if you individually strategize, if it's a low recurrence score 0 to 13, 2.3 is the benefit, and if it's a high recurrence score 14 to 25, it's 2.8% benefit. So again, very important factor and very important relevant factor per se. Next slide, please. The post hoc analysis in the pre-menopausal women, if you look at those with the nodal 1 micro invasion, protocol was amended to exclude enrollment if N1 micro invasion after 50% overall patients were randomized. Now, if you look at the 2-year landmark between the ovarian function suppression or not in the endocrine therapies, and 2-year landmark analysis between the patients with the regular menstrual period or not in between the treatment arms. Next slide, please. You could see that those with N1 microinvasion or N1 disease benefited from chemotherapy in the premenopausal women, with 7.3% in those who had a micro metastasis only, and those with 4.8% benefit in those who were given chemotherapy in premenopausal women again. Now, hazard ratio being again significant, nearly 6.64, meaning a 36% reduced risk in cases of N1 disease, while in case of micrometastasis, again, you could see nearly 56% benefit out of those who were given chemotherapies. Next slide, please.
My apologies, sir. You are just left with 1 minute to conclude.
Next slide,
the
please.
presentation. Thank you.
So again, though higher in endocrine therapy, ovarian suppression rate remains low and consistent in the ovarian functions remained low in both the arms, and that was consistent in both the arms. Next slide, please. And there was no difference in the premenopausal women if ovarian suctions were present or not in first 24 months assigned to the endocrine therapies. Next slide, please. Whatever we did. Next slide, please. In terms of the, again, whatever the regular menstrual periods were there or not. Next slide, please. Come to the conclusion for it. There was in an invasive improved DFS in patients with premenopausal women who have no longer regular menstrual periods in first 24 months, maintaining that ovarian functions should be suppressed, especially in the premenopausal women, while prescription of the endocrine therapies. Next, please. So to conclude, we report that the longer follow-up, that postmenopausal women who have a recurrence score of 0 to 25 continue not to derive any benefit from the adjuvant chemotherapies and can be put away with the chemotherapies and given endocrine therapies alone. Premenopausal women with a recurrence score of 0 to 25 do tend to benefit from the addition of the chemotherapy to the endocrine therapy, with a margin of 46% decreased risk in invasive disease-free events, in the distance relapse-free survival, and distance recurrence-free survival. And the exploratory analysis did show that even though the N1 microinvasion did benefit from the chemotherapies, but there were limited number of events, and nearly 60% in endocrine therapies and 80% in chemoendocrine therapies have stopped regular menstrual period in first 24 and have improved DFS regardless of the treatment arm. Thank you. Over to the organizers. Would love to answer any questions, and very important trial, I must say.
Hello. Yeah, am I audible?
Yes, sir, you are audible.
Okay, thank you, Dr. Vikas. What would you like to say about the use of chemotherapy in premenopausal? Do you think that all the patients in premenopausal status should receive chemotherapy? The reason why I'm asking is that we do know about the results of the Taylor-X study also, where they stratified the low recurrence score patients, that is less than 25, into 0 to 16, and then more than 16 and less than 25, and we found out that the maximum the improvement with chemotherapy was found in the intermediate risk stratification score, but here they have not done that. So do you think that we can put the low risk patients and the intermediate risk patients in the same basket, or should we really try to explore the low risk bracket more? Having said that, I will also like to say that in SABCS 2020 we had a German group study where they found out that if the recurrence score was less than 11, then those patients did not benefit from chemotherapy, and only endocrine therapy was the way to go for them.
So I believe it's a very relevant question, and I must say that this trial tries to answer a lot of them in the terms of who are these patients who actually do benefit in terms of the low recurrence score. And they have beautifully stratified based on the menopausal status, as if there's a young female with a premenopausal status, they have even though low disease burden, a low recurrence score, but again the magnitude of the benefit of the chemotherapy is large. So again, a post-menopausal woman with a low disease burden don't tend to derive benefit from the chemotherapy. So I believe the message is loud and clear right now that those where if we have a low recurrence score, we cannot even get away with the chemotherapies. We need to stratify based on whether the nodal disease was there or not, whether the uh, the nodal disease was of a micrometastasis, or whether the most important factor is the menopausal status. So whether it's a premenopausal or a postmenopausal status, they tend to have implications in the long-term effect. And again, newer trials, newer options are going to be there. We have lots and lots of combinations that are coming on. The CDK4 inhibitors are jumping into this arena and competing directly head on with the chemotherapy. So we await more and more results. But yes, for me right now, it is an eye-opener trial for us.
Hello, am I audible?
Yes, sir.
Okay, thank you, Dr. Vikas. Thank you for this nice presentation. Always a pleasure interacting with you. So now we move ahead, and the next abstract is going to be presented by Dr. Nidhi Tandon. Dr. Nidhi Tandon is a consultant medical oncologist at Mazumdar Shaw Cancer Center, Narayana Health City, Bangalore, and she is going to talk about the alternate trial which explored what should be the new adjuvant treatment that should be given to our hormone receptor positive, HER2 negative breast cancer patients. Good evening, Dr. Nidhi, over to you.
Thank you very much for the kind invitation. And as you just mentioned, I will be discussing the role of PAM50 intrinsic subtype and recurrence risk score for the prediction of endocrine sensitivity in early stage ER positive, HER2 negative post-menopausal breast cancer patients. So we have been offering neoadjuvant endocrine therapy to a lot of our patients. Most of these patients are old, infirm, or have comorbidities, but even otherwise also. Pathological complete response, as we all know, is a depiction of the sensitivity of endocrine therapy, but also something called as a modified preoperative endocrine prognostic index score of 0. So initially this combined the tumor stage, the nodal stage, Ki67, and estrogen receptor status, but then the score was modified, and tumor stage of 1 to 2, no notes, Ki67 level of less than 2.7% was considered to be a prognostic index of 0. So these two factors at the time of surgery depict endocrine sensitivity, while if on endocrine therapy, the patient has a persistent Ki67 value of more than 10% after 4 weeks of therapy, this depicts endocrine resistance. We already have data to say the intrinsic subtype and the recurrence risk score by tumor RNA profiling help to predict the effect of neoadjuvant chemotherapy. Here, the authors hypothesize that we will utilize this to predict the likelihood of getting a high Ki67 value after 4 to 12 weeks of endocrine therapy, or its ability to predict the likelihood of developing a pathological complete response or a endocrine prognostic index score of 0 at the time of surgery. So this was the alternate study design in which the authors randomized post-menopausal women who had T2 to T4 NEN and non-metastatic disease, who were strongly ER positive with an Aldrich score of 6 to 8 and HER2 new negative disease. These patients were randomized to receive neoadjuvant endocrine therapy, which could be anastrozole, fulvestrant, or a combination of anastrozole plus fulvestrant for a period of 6 months. At the week 4 or week 12, a repeat sampling was performed, and if the Ki67 score was still more than 10%, then these patients were randomized to receive neoadjuvant chemotherapy. As we discussed, the authors analyzed the PAM50 intrinsic subtype and the recurrence risk values based on mRNA sequencing and used it to predict whether it is of any benefit to predict the Ki67 level of more than 10% at week 4 or week 12, which is a marker of endocrine resistance, or a pathological complete response or an endocrine prognostic index score of 0 at the time of surgery, which is a marker of endocrine sensitivity, or a pathological complete response after neoadjuvant chemotherapy in the patients who had a high Ki67 and were randomized to receive chemotherapy instead of endocrine therapy continuance. So there were about 750 patients included in the analysis based on the pre-NAT sampling, which was sufficient in these patients. Of the 750 patients which were included in the analysis, most of the patients were luminal A or B. So 50% of the patients were luminal A and 40% of the patients were luminal B. About 7% of the patients were non-luminal. So this is important because all the patients who were included in the study were strongly ER positive with an Aldrich score of 6 to 8. Still, there were 7% of the patients who were identified to be non-luminal. The recurrence risk score was also almost equally divided between low, medium, and high, though majority were medium score. So these are the baseline characteristics of the patient. And as I just mentioned, even though these patients were strongly ER positive, still about 7% of the patients had non-luminal category. Among luminal A and luminal B category, most of the patients, about 70 to 80% of the patient had a Ki67 less than 10%. And among the non-luminal category, most of the patients were either grade 3 or had a high Ki67 more than 20%. But even in the non-luminal category, there was a significant proportion of patients who had either grade 1, 2 tumors or who had a Ki67 less than 20%. Looking at the rate of pathological complete response to neoadjuvant chemotherapy, the rates in luminal A type were 0%, in luminal B type about 6%, As regards to the recurrence risk category score, the rate of pathological complete response was about 5% in intermediate category and 9% in high category. And this is the main table which shows the result of the study. According to the PAM50 subtype, which divides into luminal A, B, and non-luminal type, the rate of Ki67 of more than 10% at week 4 or week 12, which is a sign of endocrine resistance, was significantly higher in non-luminal category as compared to luminal A or B category with a p-value of 0.0001. Similarly, the pathological complete response or a modified prognostic endocrine prognostic index of 0 at surgery was significantly depicted by a non-luminal category as compared to luminal category with a significant p-value. The recurrence risk score, whether it was low, intermediate, or high, was also able to predict endocrine sensitivity and endocrine resistance with a significant p-value. So in conclusion, PAM50 non-luminal subtype was observed in 7% of the patient despite high ER receptor status. Non-luminal types were usually associated with grade 3 tumors and high Ki67 value more than 20%, but that was not the norm. There was a significant proportion of patients without it. Ki67 value of more than 10% at week 4 or week 12 on neoadjuvant endocrine therapy, and a pathological complete response or a modified endocrine prognostic index of 0 at surgery differed significantly with respect to the PAM50 intrinsic subtype or the recurrence risk category score. PAM50 non-luminal type or a high recurrence risk score type of patients were more likely to have endocrine resistance, and this was shown by a high Ki67 value or a non-zero modified endocrine prognostic index score. For patients triaged to neoadjuvant chemotherapy, and early on in neoadjuvant chemotherapy, Ki67 of more than 10% had the highest pathological complete response. So this data suggests that PAM50 intrinsic subtype could be used to guide neoadjuvant treatment decisions in post-menopausal ER-positive HER2 negative breast cancer. Thank you.
Thank you, Dr. Nidhi, for a very nice presentation. Do you think that this information is going to be practice changing in the coming few months or years, or is it going to take some time? Especially when already there are few trials which have been conducted in the same line with the same thought in mind. Especially I'm talking about the neoadjuvant CDK4/6 inhibitors, where there was a reduction of the Ki67, but that did not really translate into a survival benefit as of now. Having said that, all those trials had a primary endpoint of Ki67 reduction only, but then the survival benefit is something that we as clinicians would like to have. So what are your thoughts on it?
I would say that it will take some more time to come into practice. First, because the results might be, as you just clearly correctly mentioned, the results would be different had we included CDK4/6 into the therapy. So plus logistically, I am not sure how often we would be able to repeat a sample at week 4 or week 12 during the therapy, or get a RNA profiling done for patients at the start of the therapy.
Yeah, certainly. Okay, thank you so much. So now we move ahead. The next abstract is going to be about the use of metformin in patients of breast cancer. And this is a randomized phase 3 trial of adjuvant metformin versus placebo in early breast cancer. And to talk about this, we have with us Dr. Kripa Bajaj. She's a consultant medical oncologist at Indo-American Hospital, Hyderabad. Dr. Kripa, good evening.
Good evening, Dr. Rajat Bajaj. Thank you so much for giving me this opportunity to share the platform with all of you. Can someone share the screen? I mean, You want me to share the slides?
Yes, ma'am. You can share your slide.
Yeah, okay. All right. So all of us have very first-hand evidence regarding the metformin usage in the breast cancer. Many of our senior colleagues used to use metformin as a maintenance post completion of treatment of breast cancer curative regimens, chemotherapy regimens. So now I'm going to answer the age-old practice of using metformin as a maintenance in breast cancer. This is by Canadian Cancer Trial, Canadian Clinical Trial Group, MA32 trial. It's a phase 3 randomized trial of effect of metformin versus placebo on recurrence and survival in early stage breast cancer. Next slide, please. So why the rationale was taken up? So the use of metformin to treat diabetes in breast cancer patients may be associated with the breast cancer outcomes was one of the finding noted in observation studies in breast cancer. So that's why it was taken as a concept and implicated in the early breast cancer management. So in this one, the patients who got included, they're not a diabetic patient, they're non-diabetic patients. Why the metformin was used? Because already there was in some observation studies, it was noted that in diabetic patients who are having breast cancer, when they're using metformin, there was a better improvement in survival was noted. So that's why the same was implicated in the non-diabetic patients who ever got like breast cancer treatment. So metformin is known to cause weight loss. It's known for reducing the insulin. There is some window of opportunity in neoadjuvant studies. It has been shown to reduce Ki67 in breast cancer cells as well. Mainly, it is an in vitro study. It's not an in vivo study though, but it was shown that metformin decreased the Ki67 index. Next slide. So this is the metformin mechanism of action. It increases the AMPK pathway. So if ever AMPK pathway got amplified, it decreases the gluconeogenesis so that there'll be a reduction in the circulating insulin levels. Usually circulating insulin levels will increase the insulin receptor activity. And again, it increases the PA3K AKT pathway leading to mTOR activation. So if ever AMPK got activated, there'll be a decrease in mTOR by action of TSC2. So there will be a decrease in protein translation, decrease in cell growth as well as proliferation. This is all about breast cancer cells. So this was the ideal situation of metformin mechanism of action. So that's why it was used in the study. So next slide. So what is the primary object of MA32 study? It is to compare invasive disease-free survival between subjects treated with metformin. The dose of metformin used in this study is 850 mg BD for 5 years versus placebo BD for 5 years in addition to standard breast cancer therapy. So the primary objective is IDFS. The secondary objective is other breast cancer outcomes like overall survival, distant disease-free survival, and breast cancer-free interval. So new diagnosis of diabetes mellitus are cardiovascular hospitalization or death, adverse events more than or equal to grade 3, BMI and circulating metabolic factors. If you see other than breast cancer outcome, the other secondary objectives are more of the metabolic and health-related one. So health rate, quality of life, trial-specific symptom checklist, diet, and all also got tested. In the baseline, the fasting blood glucose was tested, and again at intervals it got tested. Next slide. So this is the study design. So if you see the T1C to T3 and N0 to N3, N0 got included. Both ERPR positive as well as HER2 positive got included. There is no TNBC, it's more of ERPR positive and HER2 positive. All patients receive standard breast cancer therapy and they should be non-diabetic. They should have adequate organ function as well. There should not be any lactic acidosis because all of us know metformin causes lactic acidosis. Multiple groups got included in this study. The main is Canadian Cancer Trial group, but a lot of groups also got included from UK, USA, Switzerland. If you see the international enrollment is there in the study, just like our AD aspirin, the study is also a huge one. So in this study, it got stratified by ERPR status, HER2 positive versus negative, BMI, chemo, any versus none. So already discussed the randomization between the metformin 850 mg BD into 5 years versus placebo BD into 5 years. Later, the follow-up was done. Next slide. So these are the time points of the study. It started to 2010 and later 2016. There were two analyses were done. One is the primary analysis, again futility analysis, and again secondary analysis was done. So these are the time points. So August 10 to 2020 was a follow-up time, and still the follow-up is getting continued. Next slide. So the statistical analysis is the intent to treat analysis. The time to events in both arms were described by Kaplan-Meier method. So I'm not going to discuss regarding intricate details of statistical analysis. So 3 analysis I'm going to discuss. One is primary analysis. Second is follow-up of the fertility result. Third is exploratory analysis. So the crux of this study, the main findings we are going to see ERPR positive, ERPR negative, and also HER2 positive breast cancer. So there is a small group of TNBs noted, but it was not highlighted. But TNBs is also included, but it's a very small group. So the major discussion about this is exploratory analysis of the study. Next slide. Next slide, please. So first is primary analysis of ERPR positive breast cancer, regardless of the HER2 status. Next slide. Next slide, please. So if you see in ERPR positive, total number of patients included about 2,553. Both metformin or placebo versus placebo groups, both are equally randomized, and they are stratified by proper variables. So if you see age, BMI, postmenopausal status, race, ECOG status, T status, N status, grade, HER2 positivity, chemotherapy, and hormone therapy, everything, both groups are very well balanced in this study. ERPR population, if you see, next slide. So if you see the compliance of metformin is equally good like placebo, not much difference is there, it's non-specific difference. Next slide. So non-hematological toxicity in ERPR positive, no significant toxicities was noted by using metformin for 5 years. So the patient tolerated metformin quite well. 850 mg BD is like, we feel it's a major dose, but they tolerate quite well without any significant side effects. Both are having a equally balanced toxicities. Next slide. So you see the IDFS, that both curves are sitting like top on each other. There is no difference at all by using metformin in this patient. The IDFS, the primary objective, both groups are having an equal outcome. Next slide. The OS, if you see, the same result was there in the both groups. There is no difference at all by using metformin in ERPR positive patients. Next slide. The effect of metformin on ERPR positive patient, IDFS, OS, distant DFS, BCFI, all like both the hazard ratio, if you see, it's almost near 1. So there is no difference was noted. Next slide. So the conclusion of the study is the addition of metformin to standard therapy in moderate or high risk hormone receptor positive breast cancer, it did not improve IDFS OS. So it should not be usually used in a breast cancer treatment in ERPR positive population. Usually we tend to use it as a maintenance. So the study clearly proven there is no benefit of adding metformin as a maintenance in ERPR positive subjects. Next slide. So the next thing we are going to discuss is follow-up of the fertility result. This is regarding ERPR negative population irrespective of the HER2 positive. Again, mention very small group of TNBC is there. If you see that ERPR negative, the N is equal to 1,160. Again, this is a very decent number. You see the IDFS as well as OS, if you see the curves, there is no difference at all. Next slide. So that means that for ERPR negative patients as well as ERPR positive patient, irrespective of the HER2, there is no usage of using metformin as a maintenance. So hereby, no need of adding metformin as a maintenance to prevent them, irrespective of the BMI, irrespective of their status. Next slide. This is the major one. The exploratory analysis, surprisingly in HER2 positive breast cancer, interesting results were noted. Next slide. So HER2 positive breast cancer, to the topic of discussion, not only the findings which were discussed prior is important, this is also very important one. If you see, it got stratified by HER2, informed by results of 24-week neoadjuvant therapy. HER2 positive breast cancer who got treated with chemotherapy and trastuzumab plus or minus metformin for 24 weeks were noted. In those randomized to metformin, subjects with at least one CLL of pre-specified ATM. In ATM gene, if there is a one CLL got noted, in the SNP, they experience significantly high PATs here than compared to the patients who are not having a C allele. If you see this one, the one with metformin, if you see the one used in metformin, the C allele, the PATs here difference is huge. So 81.2 versus 35.3. If you see the placebo, there is no difference is there. But in HER2 with C allele, there's a good passive was noted. In the starting of the talk, I already mentioned, in vitro studies, it was noted that there is a decrease in Ki67 by use of Metformin. I'm not sure whether it was done in the ERPR positive population, but in HER2, when it was analyzed, whoever got benefit, there is a one finding got noted, is incidental or accidental, but this finding is a really good one. One who is lodging C focus in ATM gene, they're having good benefit by adding Metformin. So close to ATM gene with enhanced activity for ATM gene associated with AMPK dependent and AMPK independent differential expression of thousands of genes, the SNP, they got a benefit by adding Metformin. Next slide, please.
Ma'am, sorry for intervening. You have 1 minute left to conclude, please.
Yeah, sure. It's over. So, okay, I'll discuss the major. So the population events were noted were significantly better by usage of Metformin group. Next slide. Next slide, please. So if you see this one, these curves are very important. I'm going to discuss this in the rest. We see the HER2 positive IDFS versus HER2 in Metformin versus placebo. There's a significant difference is noted. The hazard ratio is 0.64 in IDFS. For OS, it is 0.53. The significant hazard ratios were noted for both IDFS as well as OS in patients who are positive, and whoever got benefited, the subgroup which is having a CLL, they got a very good benefit. Next slide. So if you see the IDFS and HER2 population by SNP, I'm going to highlight this one. The HER2 positive as a whole, all comers we have analyzed now with Metformin. But if subgroups were taken, so the HER2 positive with SNP CACC, they got a very good benefit compared to patients who are not having C allele, who are lodging only AA. Here the hazard ratio is 0.51, which is very significant. Here not much difference is there. In fact, it's detrimental 1.32. Next slide. So again, OS as per HER2 positive SNP CACC, again there's a good benefit is noted. With AA, it is detrimental again with hazard 2.15. Please note this point. Next slide. So again, what I discussed initially, Metformin is going to act on AMPK pathway, which will decrease the mTOR expression. It will decrease the breast cancer protein expression, cell proliferation, as well as cell growth. So Metformin is useful in HER2 positive population breast cancer who are lodging C allele in ATM gene. Next slide. So the conclusion is subjects with HER2 positive breast cancer, notably those with at least one C allele of the ATM associated SNP, experienced improved IDFS and OS with Metformin consistent with the reported Metformin effects on PCR in the neoadjuvant setting. No p-value spend was allocated to this comparison. As a result, it requires replication in a prospective trial focusing on the HER2 population. If ever anyone is really interested to pursue research in this area, better we take our population who are expressing HER2 and let us focus on the people who got benefit. And if we analyze and so sub-analyze, we'll get the right answer. We can publish in a large data set. And thank you once again, Dr. Rajat Bajaj, for giving me this opportunity. I'm happy to take any questions.
Yeah, thank you, Dr. Kripa. So I think a very important question answered about the use of Metformin in the treatment of breast cancer, and it puts rest to the fact that at least in ERPR positive, we are not going to use Metformin. There are many other cancers where still Metformin is being contemplated, be it the high-risk colon cancer or be it the prostate cancer. There we don't have the answer as of now, but with breast cancer certainly, and a very important so-called point being raised is about the HER2 positive breast cancer with a particular allele which still needs further evaluation. So thank you very much.
Thank you.
So we move ahead. We were supposed to be joined by Dr. Venkat Pradeep to talk more about important trials regarding the taxanes and anthracycline use, as well as the Olympia quality of life. We'll be joined by him after some time. And now we are going to move to the Keynote 522 study in the neoadjuvant setting in triple negative breast cancer, which was presented in this SABCS. And this abstract is going to be presented now by Dr. Rakesh Pinnati. Dr. Rakesh Pinnati is a consultant medical oncologist at the Indo-American Cancer Hospital and Research Institute, Hyderabad. Dr. Pinnati, over to you.
Yeah. Good evening to all. Thank you, Dr. Rajat Bajaj, for that introduction. So I'm going to introduce the keynote of 522 updated event-free survival sensitivity analysis and subgroup analysis. Next. So coming to the study background, we all know keynote 522. This is the first prospective randomized controlled trial that has shown the utility of pembrolizumab in early TNBC in the neoadjuvant as well as in the adjuvant setting. The primary analysis, which was previously published, has shown a significantly improved pathological complete response as well as an improved clinically meaningful event-free survival. So based upon these results, we have the US FDA approval, basically using.
Sorry for intervening. Your slides are not moving, sir.
Is it moving now?
No, sir. Just reshare again. Reshare.
Just hold on. Can you see the slides now?
Yes, sir. Please make it full screen, sir.
Are they moving now?
No, sir. Still.
I think I'll just have it in the half screen mode.
Okay.
So basically, based upon the keynote 522, we have the FDA approval for the pembrolizumab in combination with chemotherapy as both a neoadjuvant strategy as well as a single agent adjuvant treatment for patients with high risk early stage triple-negative breast cancers. So coming to the study design, this is the keynote 522. The eligible patients are triple-negative breast cancers, early stage breast cancers. These are randomized in a 2:1 fashion. In the neoadjuvant phase, we have pembrolizumab in combination with the neoadjuvant chemotherapy, which was the standard anthracycline endoxon, as well as the paclitaxel and carboplatin. Pembrolizumab was dosed at 200 mg every 3 weekly. This was the neoadjuvant phase, which starts from the first neoadjuvant treatment at the end of definitive surgery. And in the adjuvant phase, we have 27 weeks of pembrolizumab, which is given 3 weekly, basically 9 cycles of adjuvant pembrolizumab maintenance. The important thing to note here is that the adjuvant capecitabine was not allowed in this trial. So these are the endpoints of this study. The primary endpoint was pathological complete response and event-free survival, as assessed by investigator in the intensive treated population. And the secondary endpoints were pathological complete response by alternative definitions, overall survival, and pathological complete response, event-free survival, and overall survival in the PD-L1 positive patients. So coming to the exploratory analysis, which I'm going to discuss, this was done with the intention to assess the robustness and consistency of the primary event-free survival results. This was the EFS as per the patient subgroups, as well as the EFS in the sensitivity analysis. So these are the baseline characteristics of the intention to treat population. As we can see, most of the clinical characteristics which are enumerated here are equally matched in both the cohorts. So this is the primary event-free survival analysis. As we can see, the experimental group of pembrolizumab with chemotherapy significantly outperformed the control group. The event-free survival was better at 84.5% versus 76.8% at the median follow-up of nearly 40 months, and a hazard ratio of 0.63, which was statistically significant. So this is a subgroup analysis, event-free survival by nodal status. As we can see, the best performing group is the node negative with the experimental drug of pembrolizumab in combination with chemotherapy. The events were significantly less at 11.4%. The highest events were noted in node positive disease in the placebo plus chemotherapy cohort at 29.1%. This is the EFS by the overall disease stage. Again, we can see that the best performing cohort is the stage 2 disease with the experimental drug of pembrolizumab in combination with chemotherapy. The events were only 11.7%. However, the worst performing group is the stage 3 disease with placebo with chemotherapy at 39.8%. Again, hazard ratio is statistically significant at 0.68. So this is the main primary and sensitive analysis definitions of event-free survival. So in the primary analysis, patients who did not experience an event at the time of data analysis was censored at the date at which they were last known to be alive and event-free. And subsequent sensitivity analysis used an alternative censoring rules. You can see the primary analysis sensitivity 1, 2, 3, 4, 5 with alternative censoring rules. And based upon this, they have again recalculated the hazard ratio for the event-free survival. As you can see from the analysis 1 to analysis 5, the use of experimental drug of pembrolizumab in combination with chemotherapy definitely improved outcomes, especially with respect to event-free survival, with hazard ratios ranging from 0.63 to 0.65. This is a sensitivity analysis with the alternative censoring rules. Again, experimental group outperformed the control group 85.3% versus 77.9%. Hazard ratio again statistically significant at 0.64. So this is the important sensitivity analysis 3, which excluded the positive margin at last surgery as the definition from the EFS. Again, a better performing experimental group at 84.6% event-free survival compared to 77.5%. Again, hazard ratio is statistically significant 0.65. So this is the EFS forest plot describing the several hazard ratios for different subgroup analysis. Again, nodal status, disease stage, menopausal status, HER2 status. We can see uniformly across the different subgroups. Definitely, the experimental group outperform the control group of placebo with chemotherapy. So this is the outcomes of treatment-related adverse effects. As we can see, nearly 99% of both the cohorts had any grade toxicities. However, there are significantly a higher percentage of patients who had led to the adverse effects, which have led to the discontinuation of treatment in the experimental group at 27.7% compared to 14.1% in the placebo group. However, most of the adverse effects appear to be limited to the neoadjuvant phase, as because in the adjuvant phase, the treatment adverse effects leading to discontinuation were pretty less at only 4.3% in the experimental group compared to 1.8% in the placebo group. So this is the summary and conclusions. Keynote 522 definitely had shown that neoadjuvant pembrolizumab in combination with chemotherapy definitely improved pathological complete responses. It also improved meaningful improvements in the event-free survival. And this benefit is consistent across a broad selection of pre-specified patient subgroups, including the nodal status as well as the overall disease stage. Safety is consistent with known profiles of each regimen, and there's no new safety concerns. And this, in conclusion, from the author says that it's a supportive evidence for pembrolizumab in combination with chemotherapy as a neoadjuvant strategy, as well as in the adjuvant pembrolizumab after surgery, which could be a new standard of care regimen for patients with high risk early stage triple-negative breast cancers. So my takeaway from this whole trial is that it definitely raises important questions when we discuss neoadjuvant strategies with our patients. With the Olympiad data coming for the PARP inhibitors, as well as the already established Createx for the capstibin, it becomes a difficult task for the clinicians to actually make sense of all this data. If you are a true believer of pathological complete response, being a surrogate marker for overall survival, definitely it becomes an option. However, I think we need to wait for the overall survival analysis because it's a secondary endpoint, and I think in the subsequent updates, we can definitely look into the overall survival. And I think any systemic treatment in the neoadjuvant or the adjuvant phase in early breast cancer should be focusing on improving survival, especially when you are looking at such costly treatments. That is my takeaway from that. Thank you very much.
Okay. Thank you, Dr. Rakesh. So you think that right now you will not like to incorporate this in your practice, and you would want the more data to come up in the coming few years?
Yes, sir. I think there is no problem of crossover in this trial because pembrolizumab is not yet approved in the metastatic setting in the triple-negative breast cancers. So there is no problem of crossover. We can wait for a few more data updates so that we can get to a clarity about what is the overall survival advantage with this. And with already existing drugs which have shown overall survival advantage, especially in node-positive triple-negative breast cancers, which has a residual disease of a neoadjuvant treatment, showing an overall survival advantage, which is such a cheaper drug, I think we can still wait for the pembrolizumab to show overall survival advantage.
Okay, right. So more of this we'll discuss in the panel discussion. Thank you, Dr. Rakesh, for a very nice presentation. So we move ahead, and the next abstract we are going to talk about is the primary results of the C-TRACK-TN trial. This trial told us about how to utilize the circulating tumor DNA mutation to track and detect the minimal residual disease post the treatment of a high-risk early-stage triple-negative breast cancer, and whether any intervention can be done in this regard once we have detected the minimal residual disease. And to talk about this, we have with us Dr. Chirag Desai, sir. Sir, good evening. He's a senior consultant and a director in Hemato-Oncology Clinic, Vedanta, Ahmedabad. Sir, over to you.
So good evening, everyone, and thank you very much, Rajaj, for involving in this program. So we are very much used to looking at minimal residual disease and acting on the MRD in the hematological malignancies. But doing the same thing in the solid tumor is relatively new concept. And then using ctDNA to guide the further treatment is even still evolving at present. So C-TRACK-TN conducted by Royal Marsden and ICR Group, UK, is looking at the same thing. So the background of this trial is that most patients presenting with triple-negative breast cancer, at least in the early stage, are cured by current treatment. If there is any way to select who will relapse, that will help us in escalating the treatment of these patients. Detection of circulating tumor DNA in TNBC patients who have completed primary treatment is highly predictive for future relapse in the retrospective studies. So the same thing is looking at if a blood test, that is ctDNA, can identify TNBC patients who are at risk of relapse, and if so, whether any further treatment, any escalation of the treatment, whether it prevents or delay the recurrence or not. So these are the two basic questions that are being answered in this trial. So the trial, what it is doing is that if the patient is agreeing to take part and consenting at the end of all adjuvant treatment, the blood test will be carried out every 3 months for up to 2 years. If it does not indicate the increase in the ctDNA, patient completes full 2 years and then followed up every 6 months for further 3 years. But if the blood test shows that the ctDNA comes up, the patients are randomized. The patient are receiving 1 year of pembrolizumab, and 1/3 of the patient are continuing to look at the ctDNA and to look at the recurrence. So tumor tissue is evaluated to identify the potential trackable mutations, and out of various mutations that may have been detected, 1 to 2 mutations are picked up, and a personalized digital PCR ctDNA technique is developed to this ctDNA. And active DNA surveillance with blood sample every 3 months up to and potentially up to 18 months if the sample were missed because of COVID-19. So there are two co-primary endpoints. The first is rate of ctDNA detection by 12 and 24 months from the start of ctDNA surveillance, and the second is rate of sustained ctDNA clearance beyond 6 months after starting pembrolizumab. And then there are secondary endpoints which, for this paucity of time, I will not be going through. So total 208 patients were registered between January 18 to December 2019 from 16 centers in UK. 77 of them were high risk and 131 of them were moderate risk. And high risk is defined for those who received neoadjuvant chemotherapy, residual axillary lymph node positive, and if the patient who underwent a primary surgery, tumor more than 5 centimeter, any node or more than or equal to 4 nodes. And moderate risk is the neoadjuvant chemotherapy with residual invasive cancer in breast and node negative, and those who underwent primary surgery, tumor more than centimeter, or axillary microscopic or macroscopic lymph nodes positive. So look at the middle green rectangles. Total 208 patients. 161 patients were having trackable mutations, and 161 patients to ctDNA surveillance. Out of this 161 patients, 108 patients had 1 mutation that was tracked, and 53 patients had 2 mutations that was tracked. So out of this, at the end of 12 months, 45 out of this 161 patients had detectable ctDNA mutations, and for high risk, 55.7% had that detection. For 11.8% were having that detection. The remaining patients were not having ctDNA detectability. So out of these 40 patients, 14 were allocated to observation, and 32 were allocated to pembrolizumab. Out of this 14, 1 was reallocated to pembrolizumab. So it was 32 and 13. So overt metastatic disease was found at the time of detection of ctDNA in 23 out of these 32 patients. So that was too high. And out of this remaining patients, out of 9 patients with ctDNA positive without detectable disease, 4 declined treatment and 5 only started pembrolizumab. So that was not a huge number, and we don't know how what to make out of this particular trial. But to look at the results, out of 5 patients who received pembrolizumab, 4 had discontinued, 3 because of recurrence, because of adverse events, and no sustained ctDNA clearance of 6 months beyond after commencing pembrolizumab therapy. Those who were on the observation group, out of 14, actually 1 was reallocated to pembrolizumab, and then out of 9 high-risk patients, 7 had recurrence. Out of 4 moderate risk, 2 had recurrence, and 2 continued to go for ctDNA surveillance, and 2 completed 24 months of ctDNA surveillance, high and moderate risk respectively. So in observation group, what we can see in the diamond over here is that proportion of the recurrence-free ctDNA clearance after 6 months in observation group is 21.4%. That is 3 of 14%, 3 of 14 patients. And what it concludes is that CTRAC-TN trial is the first prospective trial to analyze the proof of principle to look at ctDNA and to treat the patient with pembrolizumab. At enrollment, the patient had relatively high rate of diagnosed metastatic disease when imaged, and relatively few patients commenced the pembrolizumab treatment. So we cannot make out anything out of this. So what the authors conclude is that start ctDNA testing early when the patient is on capecitabine therapy after neoadjuvant therapy. Employ more sensitive ctDNA assays that can track multiple variants. Potentially more frequent testing in first 6 months, given the rapidity of disease evolution, and consider adjuvant cancer. I already said that highest risk patient may not be appropriate for ctDNA surveillance. So my take out of this study is this is a new kind of study design for future in line with biological malignancy, but we are just at the door of the new era. So we don't know how to go ahead for this kind of patient. I will draw your attention to one trial of ETC at the end of 5 years of adjuvant hormonal therapy, and that showed that ETCs are still possible at the end of 5 years of therapy. Patients are benefited by extending the hormonal therapy beyond 5 years. So this is another study which is prospective study. So thank you very much for this opportunity.
Thank you very much, sir, for this crisp presentation. So you think that this trial is more of futuristic as of now, and it is not going to be applicable in the near future in our practice?
Absolutely. I mean, I don't see any such trial being brought into practice for next 2-3 years at least.
Yes, yes. Right. Thank you so much. Thank you, sir.
Thank
so
you.
After this abstract, we move to the next abstract. This is going to be presented by Dr. Shefali Sardana. She's a senior consultant medical oncologist at Max Super Specialty Hospital, Delhi. And she's going to talk about the Destiny 03 trial, which is going to be the trial between TDX and TDM1 in patients of HER2 positive metastatic breast cancer. Dr. Shefali?
Yeah, good evening, everyone. Can I share my screen?
Yes, ma'am, you can.
Yeah. So, so is the screen visible?
Yes, yes, it's visible and you're audible. Yes.
Yeah, sure. Thank you. So good evening, everyone. So interesting abstract, which I'll be discussing right now. So wonderful drugs, both of them, and wonderful comparison between the standard of care drugs. So we know that trastuzumab deruxtecan has shown promising results in the refractory settings post multiple line treatment. And now this updated analysis from Destiny Breast 03, which actually may be a practice-changing trial, considering the preliminary results what we have. So this trial actually head-to-head compared TDX-D with TDM1 in second-line setting. Most of the patients were in second-line setting, though a reasonable was post-2 lines therapy also. And this trial was conducted in unresectable metastatic HER2-positive breast cancers, where we are looking forward to a population who progresses to brain metastasis early, and where we actually are finding out a way forward, a wonderful step forward, which can actually curtail the progression of disease. So Destiny Breast 03 is such kind of study. It's randomized phase 3 study of trastuzumab deruxtecan versus TDM1, and it was conducted in unresectable metastatic HER2 positive patients. And if these the good point was that a good chunk of population who had brain metastasis were included, and patients who had clinically stable already treated brain metastasis, as well as patients who were now found to have a brain metastasis and who were undergoing treatment for it. So more than 2 weeks gap was taken as a starting point between the whole brain and the starting and enrollment of the patient in the study. So these patients were further stratified into hormone receptor status groups and whether they received pertuzumab or what was the burden of visceral disease. So they were 1:1 randomized into trastuzumab deruxtecan group versus TDM1, 3-weekly regimen. And the primary endpoint was PFS, which was also studied by blindly independent committee review. And the secondary endpoints was overall survival, overall response rate, and duration of response, including PFS. And you can see that baseline characteristics of the patients were reasonably matched in both of the groups. And important to highlight is the patients with history of brain metastasis who were clinically stable and pre-treated, good chunk of patients in this subgroup, and 23% versus 19% in either of the groups, and patients who had baseline brain metastasis and who were receiving treatment, so 16.5 versus 14.8%. And quite a reasonable 50% patient had at least 0 to 1 line treated who received trastuzumab and taxane at least. And there were 49 to 50% of the patients who were basically post 2 lines of therapy also. So if you see the primary endpoint, which was PFS by independent committee review, so there was a tremendous 12-month PFS rate of 75.8%. And at the time of data cutoff, which was 15.9 months of follow-up, so 32.2% patients treated with trastuzumab deruxtecan progressed versus 58% in the TDM1 arm. So again, quite impressive results. If we tend to see the subgroups, so TDXD did fairly well over and above TDM1 in all of the subgroups, be it hormone receptor status, where it was 22.4 months versus 6.9 months, be it patients who received pertuzumab prior. So the median PFS was not reached versus 6.8 months in this subgroup, be it the visceral disease or the number of lines of therapy. So having said that, there was a clear-cut swipe off in terms of the results in favor of trastuzumab deruxtecan versus TDM1. And if we see the confirmed overall response rate across different patient subgroups, again, we see that difference of the response rate, overall response rate favored clearly in favor of the trastuzumab deruxtecan versus TDM1. You pick up any subgroup and it had made a difference. And if we see the progression-free survival in the Kaplan-Meier curves for patients with and without brain metastasis, you can clearly see the separation of curves wonderfully. And patients who had brain metastasis at baseline, impressive hazard ratio of 0.25 in favor of trastuzumab deruxtecan versus the TDM1. And also in patients who did not have brain metastasis at baseline, again, the ratio favored reasonably well of 0.30. Now, if we come to confirmed overall response rate and best overall response, you can see that a good chunk of patient in trastuzumab deruxtecan arm had a CR as compared to the patient with on TDM1 arm. And so this also again confirmed that trastuzumab deruxtecan works fairly well in be it the treatment first line prior to first line of treatment or the treatment refractory disease. If we see this is very important subgroup where we see the intracranial response, where we are actually struggling in the HER2 positive patient to have a drug which actually did fairly well in the CNS because these patients we know do progress in brain. So trastuzumab deruxtecan again, scored over and above TDM1. So approximately 27% of the patient had CR as compared to 2.8 in TDM1 arm, and 36.1% had PR in the TDXD arm as compared to TDM1. So when we saw the safety analysis and the exposure adjusted incidence rates, so grade 3 events were slightly higher in the trastuzumab deruxtecan arm and as compared to the TDM1, but more of these were quite manageable in terms of neutropenia, except for the interstitial lung disease, which was significantly higher in trastuzumab deruxtecan arm as compared to TDM1. But most of these interstitial diseases were of the variety of grade 1 or grade 2, of the severity of grade 1 or grade 2 rather than grade 3. So a fairly well tolerable, and once we are looking for such a good response rate in the refractory or difficult to treat population, I think this drug scores fairly well over and above TDM1 in this setting. So interstitial lung disease and pneumonitis incidence, as I highlighted, was more in trastuzumab deruxtecan arm as compared to TDM1, but Again, wonderful response. So way balance your patient population, your choice of patients. So to conclude this trial, this subgroup analysis, updated analysis clearly showed that trastuzumab deruxtecan treatment demonstrated consistent efficacy benefit in terms of both PFS and overall response rate over TDM1 across all patient subgroups. And in patients with or without brain metastasis, this drug resulted in greater efficacy as compared to TDM1. And this trastuzumab deruxtecan is associated with substantial intracranial response and reduction in CNS progression with a tolerable and manageable safety profile. So my take on this abstract is, though we saw that in the preliminary results, the good PFS, overall response rate, and overall survival also favored in favor of trastuzumab deruxtecan, though the p-value did not cross that pre-specified analysis with the statistical significance. But till now we have a little early or premature data, so let's wait for more data for OS. But in these kind of population where we are struggling to have a response and a PFS, I think there is no doubt about that trastuzumab deruxtecan is going to make its place in the second line. The only limitation is availability of this drug globally. So I rest my discussion after this thing, and thank you so much for patient listening.
Thank you, Dr. Shefali. So do you agree that you've got the best abstract to present out of all the abstracts which are being presented?
I do agree in terms of discussion, in terms of the results. I mean,
so everything is good in this abstract, isn't it? It is pitched against the standard of care, intracranial responses to the tune of 75%, 80%, extracranial responses also to that measure. So I don't think you can have a better abstract if you would have asked for one.
I completely agree with you, but we
of course availability is an issue.
Yeah, medical science always throws up some survival till we have a long-term result. But these results are convincingly good enough to have given the patient both of the options in the second line if the availability or access is there. I do agree with it. Yeah. Thank you.
Certainly, yeah. Thank you so much. Thank you for being there. Thank you. So now we move ahead, and the next abstract is going to be on the a new CDK7 inhibitor that we have, which is called semuracyclib. Semuracyclib in combination with fulvestrant in hormone receptor positive HER2 negative breast cancer. And to talk about semuracyclib and its related study, we have with us Dr. Shruti Kate. She is a senior consultant and HOD in HCG Manavta Center, Nashik. Dr. Shruti, good evening. Please take it forward.
Thank you, Dr. Rajat. Thank you for the opportunity. Could you please put up my slides, Arham? Thank you, Palak. So I'm presenting the study of semuracyclib, a first-in-class oral selective inhibitor of CDK7 in combination with fulvestrant in patients with advanced hormone receptor positive HER2 negative breast cancer. This was presented by Dr. Coombs in the SABCS. Next slide, please. Next slide, please. So there, we all agree with the unmet need in advanced HR positive HER2 negative patients who progress on CDK4/6 inhibitors. We do not have current agreed standard of care. So first line standard of care is CDK4/6 plus aromatase inhibitor or CDK4/6 plus a SERD. And key treatment options following progression could be either chemotherapy, mTOR inhibitors, or PIK3CA inhibitors. But these are all unsatisfactory in terms of efficacy or toxicity. And many a times these patients develop myelosuppression, neuropathy, skin reactions, pneumonitis, hyperglycemia specific to PIK3CA inhibitors, alopecia. So hormonal therapy is well tolerated, but efficacy is limited following prior CDK4/6 inhibitor therapy. Next slide, please. So introducing CDK7 inhibitor semuracyclib. It's a once daily oral small molecule ATP competitive selective inhibitor of CDK 7. So this has synergistic effect with hormonal therapy in HR positive breast cancer. In the xenograft models, it has been found to block the CDK7 mediated oncogenic effects in 3 ways. What it does is through the phosphorylation of other CDK7s, it inhibits the cell cycle. Then it inhibits, it causes the transcription of oncogenic and anti-apoptotic genes. And then it inhibits the signaling and activation of hormone receptors, both ER and AR. Next slide, please. So in the xenograft models, it has been seen that samuracyclib inhibition is strongest in combination, either with tamoxifen or fulvestrant, via the direct inhibition of the ER phosphorylation. Next slide, please. So this is the design of this study. It's a phase 1 study. Female patients who were above the age of 18 years and had histologically confirmed metastatic or locally advanced HR positive HER2 negative breast cancer with measurable disease were included. Prior CDK4/6 therapy was allowed. No prior fulvestrant was allowed. And patient could have received either 1 or less lines of chemotherapy or 2 or less lines of endocrine therapy for advanced breast cancer. These were subjected to 2 dosages, samuracyclib in 240 mg per day with fulvestrant 500 mg every month. And then in the next step, the dose was escalated to 360 mg per day along with the same dose of fulvestrant. So 6 patients were first given the phase 1 dosing, and then that was the dose was increased for these for the 25 patients. The objective of the study was to determine the dosing regime of samuracyclib and fulvestrant to be taken into a subsequent randomized phase 2 trial, and to investigate the preliminary signs of activity and potential biomarkers. So analysis was an intention to treat analysis for all the study participants, the basic demographics, PFS analysis, and response evaluation. Next slide, please. At least those who had received 1 dose of samuracyclib. So this is the baseline characteristic. Median age was 60. All the patients were females. All of them had measurable disease. All of them had hormone positive disease, and a majority had visceral disease. Also, if you see around nearly half of them had liver disease, and majority of them had at least received 1 line of therapy, endocrine therapy, and a prior CDK4/6 therapy was also received in 100% of the patients. Next slide, please. So these are the preliminary results, and samuracyclib based therapy shows a durable efficacy. You can see here that the overall clinical benefit rate at 24 weeks is 36%. In the patient who did not have liver metastasis, it was 55%. And those who had a TP53 wild type, the clinical benefit rate at 24 weeks was 53%. So here you can see that this has definitely surpassed the PFS achieved in the SOLAR-1 Veronica study. Next slide, please. So if you see that the best RECIST response confirms that samuracyclib-based therapy is quite active. 72% of the patients had a tumor shrinkage. Next slide, please. And if you look at the median PFS by the TP53 status, so those who were wild type for TP53, the median PFS was 32 weeks as compared to those who were mutated. So this difference in the PFS as per the TP53 status was statistically significant. Next slide, please. So it's an important biomarker to choose the subsequent therapy in this group of patients. So what what they have explained it in the form is that tumor TP53 status is predictive of the outcome of samuracyclib therapy, and definitely the impact is greater than what is reported. Preclinical data indicates that CDK7 inhibition activates the TP53 pathway. in the wild type patients. And this activation by samuracyclib appears to work in combination with other effects of CDK7 inhibition also to control the cancer growth. So if we look at the patients with TP53 wild type tumors, which represent 70% of the patients in this setting, it means that samuracyclib has a very good potential to benefit the majority of the patients. Next slide, please. So this is the median PFS by baseline liver metastasis. So median PFS was not achieved for patients who did not have baseline liver metastasis. So again, the biology of the disease is the one that could be relating to that, but definitely these are factors which would help you to choose a particular drug in future. We are very, very far away from that point as of now, but presence of liver metastasis is a known risk factor, and the strength of the effect observed here suggested that liver metastasis has a predictive potential for clinical benefit from samuracyclib based therapy. So if the liver metastasis was there, the median PFS was 11.9 months versus no liver metastasis. Next slide, please. If you look at the side effect profile, there were definitely adverse events in more than 10% of the patients, but they were in majority, they were low grade GI events which were reversible. Of the 11 patients who did require dose reduction, 9 continued on treatment. There was no neutropenia or significant myelosuppression that was observed, and long-term samuracyclib administration was achieved in many patients, and only 6 discontinued due to GI events. So ondansetron prophylaxis is also a routine that has been advocated for this drug. Next slide, please. So it is safe to conclude that samuracyclib plus fulvestrant is an active CDK4/6 inhibitor in CDK4/6 inhibitor pre-treated HR positive breast cancer patients. Baseline tumor TP53 wild type status as per the ctDNA measurement, it predicts the extended benefit from samuracyclib based therapy in these patients. Samuracyclib will be co-administered with other oral SERDs in future clinical studies. This is what we are on the lookout for, to extend the limited PFS benefit of the single agent endocrine therapy, and based on this, it has been granted a fast track status by the US FDA. So my take on this is an interesting drug, and we are definitely in need for more therapies in this group of patients, and we are on the lookout for further clinical trials on samuracyclib, and we need to see the updated mature data for these patients, and definitely it gives a very, very positive future direction. Thank you.
Thank you, Dr. Shruti. Very nice and crisp presentation. So you think that nowadays the investigators have stopped looking at the first line options for hormone receptor positive, HER2 negative, because now that is saturated with CDK4/6 inhibitors, and they're looking for second line options because that is the unmet need. And probably this drug in times to come will fill that unmet gap that we have. The data looks good, although of course it is a phase 1 study.
Yes. Yes, so I agree that standard of care in the first line setting is established. However, as the approvals proceed, drug could be pushed earlier. That could be something that may happen in the future, but yes, as of now we need something in the second line setting, and once it establishes its place, like we are seeing for deruxtecan, it is being pushed higher and higher into the treatment of patients who are HER positive. So right now the unmet need is in the second line setting, but fingers crossed for everything.
Yes, right. Thank you so much. Always a pleasure interacting with you. Thank you. So now we move ahead, and the other next abstract, and in the similar setting, that is in the second line treatment of ER positive, HER2 negative advanced metastatic breast cancer, is the Emerald phase 3 trial, which was presented in this SABCS. And to present this abstract here, we have with us Dr. Rishabh Kothari, who's the founder director, Oncovin Cancer Center, Ahmedabad. Dr. Rishabh, good evening. Over to you.
Good evening. Thank you, Rajat, for the second line hormone positive post CDK4/6 inhibitor, where investigator choice of endocrine monotherapy is compared with oral SERD, which is Alexistrant. Next slide, please. So as we all know, CDK4/6 inhibitor is now mainstay of hormone positive HER2 negative and is established in first line treatment. And most patients at some point of time will progress on it, and following that, endocrine therapy options are not exciting, especially in patients with mutation ESR1 mutations. So as we are aware from the previous trials that single agent endocrine therapy like fulvestrant had poor median progression-free survival of around 2 months in second and third line post CDK4/6 inhibitors, which highlights that there is a need for a better treatment. Alexistrant is oral SERD that blocks ER receptor, and it inhibits estradiol-dependent gene transcription induction and cell proliferation. So it seems that it is having some more mechanism than fulvestrant. It is a phase 3 study where there is 1:1 randomization to oral SERD versus investigator's choice of single agent endocrine therapy, fulvestrant, anastrozole, letrozole, or exemestane. Inclusion criteria: men and postmenopausal women with advanced metastatic breast cancer, ER positive, HER2 negative, progressed or relapsed on after 1 or 2 lines of endocrine therapy, of which one has to be CDK4/6 inhibitor, less than or equal to 1 line of chemotherapy, and with good ECOG PS of 0 or 1. It was stratified with ESR1 mutation status, prior treatment with fulvestrant, and presence of visceral mets. Next slide, please. The primary endpoints were PFS among all patients and PFS among patients with mutated ESR1. And key secondary endpoint was overall survival, both in all patients and in patients with ESR1 mutations. Next slide, please. So these are the baseline demographics, which shows that both the groups were quite balanced. Visceral mets was there in around 70% of the patients. In both the arms, number of prior lines of chemotherapy was around 75 to 80% patients had no prior chemotherapy, and around 20 to 25% patients had 1 prior chemotherapy. For lines of endocrine therapy, around 54 to 60% patients had 1 line of prior endocrine therapy, and around 40 to 45% patient had prior 2 lines of endocrine therapy. Next slide, please. So this is a Kaplan-Meier curve for all patients for PFS. So as we can see that median PFS is 2.79 versus 1.91 month, with hazard ratio of 0.697, confidence interval not crossing unity, and a significant p-value. So around there is 30% reduction in risk reduction in progression or death in all patients with hormone positive HER2 negative. So statistically, it is a significant finding. Next slide, please. So PFS in patients having ESR1 mutation, it was a bit better, 3.78 versus 1.87 months, with good p-value and hazard ratio of 0.54, not crossing unity. Again, indicating that there is significant improvement statistically versus standard of care. Next slide, please. So PFS at time point of 6 and 12 months in all patients and in mutated patients. Again, at 6 months, it is 34.3% versus 20.4%. At 12 months, it is 22.3% versus 9.4%. And in patients with ESR1 mutation, 40.8 versus 19.1 at 6 months, and 26.8% versus 8.2% at 12 months. Indicating that even PFS at 6 and 12 months is better with oral SERD than other standard of care. Next slide, please. Now, comparison with fulvestrant, whether this oral SERD has something better than that. So for all patients, the median PFS is 2.79 versus 1.94, with a significant p-value and hazard ratio of 0.684, not crossing unity. And in patients with mutated ESR1, it is 3.78 versus 1.87, with good p-value and a hazard ratio whose confidence interval is not crossing unity, showing that oral SERD had significant improvement versus fulvestrant as standard of care in these populations. Next slide, please. So when we see the subgroup analysis, we can see that most of the patients are benefiting with oral SERD than standard of care, irrespective of prior lines of chemotherapy, prior lines of endocrine therapy, performance status. Important thing to note is that there are some diamonds crossing line of unity. So absolute differences are small and population in some groups are not high in number. There can be some fallacies which we need to look for in subgroup analysis. Next slide, please. So overall survival, we don't have final analysis. This is an interim analysis, which is showing that both in all intention to treat population in patients with ESR1 mutation, it seems that there is trend of better overall survival, but as of now, it is not statistically significant. Next slide, please. Safety. So now we have a drug which seems to be better in efficacy than what we traditionally use. Then the next important question is, what is the toxicity profile? So again, when compared with standard of care, toxicity profile, grade 3 and grade 4 toxicities were comparable, a bit higher, 7.2% versus 3.1% in oral SERD arm, and dose reduction was around 2.5% versus none, and discontinuation of study drug was around 3.4% versus 0.9%. So there are some discontinuation, but it is not significant in number, and there was no treatment related death in either of the group. So it looks like the drug is pretty tolerable. Next slide, please. Again, this is split in toxicity. What are the toxicities which we see with oral SERD, which are more than our routine standard of care? So there are more GI toxicities in form of nausea, vomiting, decreased appetite, diarrhea, and there is some increase in fatigue, loss of appetite, transaminitis. Next slide, please. So as of now, from whatever data we have, it seems that oral SERD has statistically significant and clinically meaningful improvement in PFS versus standard of care in second line CDK4/6 inhibitor in hormone positive HER2 negative, both in intention to treat population and in patients with ESR1 mutation. I'm a bit more interested in population who has ESR1 mutations because traditionally they do worse with fulvestrant or other aromatase inhibitor. Again, there was higher PFS at 6 months and 12 months. So, and toxicity profile is like largely similar with both the drug, oral SERD or fulvestrant. And these results were consistent even when compared with fulvestrant. So if we remove or aromatase inhibitor in the standard of care arm, still the results were consistent. So it seems that there is a well-tolerated oral SERD which can be used in place of fulvestrant in second line setting. The absolute numbers or absolute improvement in PFS is not something which will excite us as it would be in TDXD, but still it is a move forward for all of us. Next slide. I think this is the last slide. Thank you.
Yeah, thank you, Dr. Rishabh. I think very well put that this is definitely one of the options that we'll have in the coming times. Availability still is an issue here, but these are good results. Free of ESR1 mutations, the PFS benefit has been seen. And like I was talking to Dr. Shruti also, this is the subset where this is the line where the subset of these patients do not have much of treatment after a CDK4/6 inhibition. So I think in times to come we'll have this space filled up with this particular molecule. Thank you. So we have Dr. Venkat with us. Dr. Venkat.
Yes, I am here.
Yeah, Dr. Venkat, good evening. So Dr. Venkat, over to you for your two abstract presentations.
Yeah. Thank you, Dr. Rajat, for having me here. Good evening, Piyush Bajpai sir, Tipu Sahu sir, and all other senior consultants and my colleagues. Today, I am going to present two important abstracts, two interesting abstracts, in fact, that are present in SABCS. So the first abstract is about the meta-analysis that was done to look at the role of anthracycline in early breast cancer. So taxane with anthracycline versus taxane without anthracycline, a patient-level meta-analysis. The background is that we have several randomized controlled trials which comparing the same concept previously, but much with a conflicting results. So this meta-analysis was done with the intention to see whether
sorry for intervening, your slides are not moving.
Are they moving, Arham?
No, sir.
You have to do it full screen first.
So I did, sir.
Reshare, sir.
Reshare,
Reshare,
yeah. Arham, are they moving?
Yes, sir. Moving, but not in full screen.
I did the full screen. Now is it full screen, Arham? I did it.
No, sir.
Okay, shall I continue in this mode because I did it?
Yes, sir. You can. Yes.
Yeah, thanks. So the main concern about adding anthracycline is that anthracycline may cause cardiovascular toxicity and leukemia in the long term. And of course, taxane can cause neuropathy. But whether there is increased mortality because of adding anthracycline to the taxane regimen, and really can we avoid anthracycline in early breast cancer is an important question. And that frequently comes up in tumor board discussions as well. So the aim of this study is to better categorize the benefits and risks of anthracycline versus taxane alone for early stage breast cancer. So this meta-analysis, it included the patient level data from all the randomized trials that was started before 2012, and all trials included those trials with at least patient receiving 6 cycles of chemotherapy in each arm. The
Sir,
primary
still your
outcomes,
slides are not moving, sir.
the primary, can you share it? I will stop sharing.
Yes,
Can
sir.
you
Yes,
share
sir.
it?
Yes.
Yeah, please do. Please share in the PPT mode, please.
Yes, sir. I have shared, sir.
Okay. I think there is some problem. I cannot actually see that. I cannot see in the PPT mode. I think there is some problem with the link shared to me. Can you share it again? Sorry for the interruption. Yeah.
Yeah.
Now I can
know,
see.
it's okay.
Next slide, please. Yeah. So in the meta-analysis, there are the 4 groups of trials that were included. The first group A is the concurrent anthracycline and taxane. There are 3 trials with this, and there are nearly 2,500 patients included with this. And group B, C, and D are the sequential anthracycline and taxane with comparatively higher doses of docetaxel in the other arms. So, but we should remember that in the group B, what are the cycles that were given? Majority of the 3 are there 3 weekly cycles. Next slide, please. So the combined analysis of all the 16 trials from group A to D, when we see the recurrence at 10 years, absolute benefit is 2.5% with adding anthracycline compared to not adding anthracycline. When we see the mortality, nearly there is 1.6% benefit at 10 years. Next slide, please. When we see this forest plot, we can see only the first group A is not meeting the line of unity, which means the benefit of adding anthracycline is much more prominent and is being seen only with the concurrent anthracycline and taxane group. Next slide, please. So this individual patient data of nearly 13,800 patients in the 11 trials, they have stratified into ER positive, node positive, and HER2 positive disease, and they are well balanced between group A and group B. Next slide, please. So this is the comparison between group A and group B, where the concurrent docetaxel plus cyclophosphamide versus sequential. Next slide, please. When we see the concurrent versus sequential anthracycline, the left side graph indicates the concurrent where there is the benefit of 10 years is 8.7%. In the sequential arm, it is nearly 0.6%, which means the predominant benefit of adding anthracycline is being seen in the concurrent regimens compared to the sequential regimens. But these sequential regimens, again, I want to pronounce that these are not dose-dense regimens that are compared in these trials. It is 3-weekly regimens. Next slide, please. In the same way, when we see the mortality with the concurrent regimens, the 10 years mortality benefit is nearly 4.2% by adding anthracycline, while it is only 0.3% in the sequential regimens. Next slide, please. In the same way, when we compare the ER negative and ER positive, the predominant benefit is in those patients with hormone negative patients, which is quite obvious. Next slide, please. In the nodal status, the benefit of adding anthracycline is much more pronounced in N0 status compared to the N1 to N3. Next slide, please. And coming to the toxicity and quality of life analysis, there is no difference in the deaths from cardiovascular disease or leukemia in this patient when in the anthracycline arm compared to the taxane only arm. Next slide, please. But one of the most important point we need to remember is this is the interim analysis. This is not the final analysis of this thing. And 15% of proportional reduction and 2.5% of absolute reduction at 10 years is seen by adding anthracycline compared to the regimen which are avoiding anthracycline. So the question is, can we avoid anthracycline in early breast cancer? Maybe not. And now the question again comes up, why there is so much difference in the sequential regimens compared to the dose-dense regimen? The reason we have already discussed. One of the discussion question that has raised during the discussion of this abstract is that, and one of the expert answer is that maybe the benefit which is not being seen in the 3-weekly regimens, it is the cumulative dose is more important. So the benefit is seen in dose-dense regimens, even though when we give in a sequence. Next slide, please. Thank you. Please move on to the second abstract. Can you make into PowerPoint show mode?
Yes, sir, I did.
I can't see it. Yeah. So the second abstract is about the quality of life results from Olympia trial, adjuvant olaparib in a patients who have received neoadjuvant chemotherapy. Whether quality of life is deteriorated by adding olaparib in the adjuvant setting. Next slide, please. We all know that Olympia is a randomized double-blind placebo-controlled trial of adjuvant therapy with olaparib in high-risk breast cancer patients with germline mutations of BRCA1 and 2. So these patients in the control arm these patients and the experimental arm received olaparib for 1 year, while the other arm received placebo only for 1 year after the primary treatment, that is neoadjuvant therapy, chemotherapy. So this is an interim analysis done for the assessment of quality of life. Next slide, please. Why this separate analysis of quality of life is done in the Olympia trial? Because already patient has received chemotherapy and they have substantial acute toxicity in the early breast cancer with a delayed recovery often lasting of 1 to 2 years. So these toxicities, particularly fatigue, is also seen with the most important side effect of olaparib also. So now the question is whether giving olaparib in the adjuvant therapy after in those patients who have already received the neoadjuvant chemotherapy, is it deteriorating the quality of life in terms of fatigue, nausea and vomiting, diarrhea, etc. All these things were evaluated in this abstract. Next slide, please. So this is the trial schema. This is the same schema as Olympia trial. So I'm not going into the details, but this is the 1:1 randomization of olaparib versus placebo for 1 year. And it is assessed at 6 months, 12 months, 18 months, and 24 months. Our primary assessment of the quality of life is done at 6 months and 12 months, and whether they are being recovered by 18 months and 24 months is also tested in this study. Next slide, please. So the primary hypothesis they have proposed in this analysis is that patients who are receiving olaparib, they may experience greater fatigue severity at 6 and 12 months compared to those who are not receiving it, or those who are receiving only placebo. The secondary hypothesis is that there are no difference in the fatigue severity between olaparib and placebo post-treatment measures at 1.5 years and 2 years intervals. And patients treated with olaparib, the secondary objectives they have determined about variables such as fatigue using FACIT fatigue scale, GI symptoms, particularly nausea, vomiting, and diarrhea using EORTC scales, and other subscales like physical and emotional subscales and global health status, QOL. Next slide, please. So how they have analyzed using the EORTC scales. So assessment was planned in those patients with a 3-point difference on FACIT fatigue scale is significant and considered as a clinically meaningful difference. Next slide, please. Next slide. So these are the characteristics of the patient's demographic characters, which are well balanced between olaparib and placebo. There is nothing much to discuss in this style. So white, Asian, black, all the subsets were included. Next slide, please. So as you have discussed, FACIT is the standard scale to assess the fatigue, and it was assessed at 6 months, 1 year, 1.5 years, and 2 years. And mean FACIT fatigue in healthy females was 43, which is baseline score is much worse in the Olympia patients. In the FACIT score, the higher the score, the less is the fatigue. Here we can see that the differences at 6 and 12 months is -1.3 and -1.5. These negative numbers, they indicate the increase in fatigue in the olaparib treatment patients. But when we see at the end analysis at the 6 months and the 12 months, it was seen that the difference was not statistically significant. Although numerically, it seems that patients who are receiving olaparib, they might experience more fatigue. Numerically, it seems in the data, but it is not statistically significant. Next slide, please. Similarly, in the lines of fatigue, when we analyze the other characteristics like GI scales and etc. Next slide, please. So this is the EORTC quality of life C30 nausea and vomiting that was measured over the 24 months. And there is no difference at 18 months and 24 months in those patients who are receiving olaparib compared to placebo, which means that whether nausea and vomiting, even though they are mainly prominent at 6 and 12 months, they are being normalized by the end of 2 years and is returning to the pre-treatment levels. In the same way, the diarrhea also, there is no difference between the patients receiving olaparib and placebo. Next slide, please. The same results are observed with the physical functioning as well as the emotional functioning, that their patients with olaparib are not affected compared to those receiving the placebo at 2 years. Next slide, please. Yeah, same with the emotional functioning also. Next slide, please. And finally, global health status. The result is same. There is no difference. Global health is not affected by olaparib. Next slide, please. So coming to the conclusions, the primary quality of life outcome, that is the fatigue, the severity difference between olaparib and placebo at 6 and 12 months did not meet the protocol pre-specified clinically meaningful difference, which means that the fatigue is not really severe, which we normally think before instituting olaparib at 6 and 12 months. The only thing that is significant at 6 months and 12 months is nausea and vomiting because of olaparib. However, when we can manage with effective antiemetics available, and it is nausea and vomiting also becomes normal at the levels of 18 and 24 months. Next slide, please. One of the main limitations for this quality of life analysis is the data cutoff is not complete and it is an interim analysis. Maybe further long-term data cutoff will give a much more clear idea, particularly in terms of fatigue and nausea and vomiting, but it is persistent for a much longer time. Thank you. With this, I rest my discussion. Thank you.
Thank you, Dr. Venkat. We'll take up these two abstracts in the panel discussion as well. Thank you very much. So now we move to the panel discussion, and to moderate this panel discussion, we have with us Dr. Piyush Bajpai, sir. Sir, good evening. He is Senior Consultant and Head of the Department in Medical Oncology at Manipal Hospital, Dwarka. And sir, will you like to call your panelists?
Yeah, thanks, Dr. Rajat, and good evening to all. I hope my slides are visible.
Yes, they are. Yes.
Okay, so I had actually made this panel discussion for these three particular abstracts which were sent to me: Destiny Breast 03, Emerald, and Samuracycline. So I would like to invite my panelists, Dr. Kshitij Joshi, Dr. Prasad Narayanan, Dr. Amitabh Upadhyay, and Dr. Chaturbhuj Agarwal. Are they all there? I can see Dr. Chaturbhuj.
Hi. Yes, sir, I'm here.
Hi.
Dr. Kshitij is there.
Yeah, hi, Dr. Kshitij.
Dr. Chaturbhuj, I'm also here.
Hello,
Dr. Prasad, I'm there, yeah.
Hello, sir. So just to take it forward, Destiny Breast 03 is the first abstract, and if Dr. Shefali is there, she can also be, she can also throw some light over here. She just presented this. And this was the trial design. Here we see that in metastatic HER2 positive scenario where patients were pre-treated with taxane and trastuzumab. These patients were eligible, and this is positioned, this particular molecule is being positioned in the second line. And this was compared with TDM1. Here the brain metastases were pre-treated, or patients who were on treatment after 2 weeks, they were to be started on the, they were enrolled in the trial. And the primary endpoint, as we see, is the PFS. And we saw some impressive graphs. This was 12-month PFS was very impressive, 75%, as we can see. And the TDM1 also, we can see good results, but of course, this is a huge PFS benefit that we are getting. Now, confirmed ORR across all patient subgroups, we saw it's working in every subgroup, whether it be hormone receptor, whether it be prior pertuzumab treatment as well, and visceral disease. So all subgroups are benefiting over here. And of course, brain metastasis, as Dr. Shivali mentioned, that that's one of the hard sites for her to new. And now these molecules are coming up. So my questions, and this is directed to all panelists. Do you regularly screen for brain metastasis in HER2-new MBC? Or is it like a regular screen? Do you do anything beyond PET-CT? Has time come to take it as like lung? I mean, of course, with the drugs available. Dr. Prasad, sir.
Yeah, so I don't do, I mean, all the patients get a PET-CT, most of the patients. So I don't do a specific MRI imaging in HER2 positive breast cancer metastatic disease, unless there is an issue, there's a symptom.
And now if these drugs are there available to you, what would your thoughts change? Is it like something like what we are seeing in an ALK scenario, or?
See, I don't think that the impact of the drug is different if there is no brain metastasis, right? It's a winner. It's a straightforward winner. If the drug is available, I will use it regardless of brain metastasis. But if there is brain metastasis and we have to use, we have a choice, maybe we can, this drug, I mean, the Deruxtecan and our tucatinib, pyrotinib, they take precedence over the existing treatments.
Right. So definitely, you rightly said that. Dr. Kshitij, your thoughts?
I agree with Dr. Prasad that we do not usually regularly do brain MRI unless and until patient is symptomatic for brain disease. And but this is
with
a
these
current
two drugs being available, would you do that? So is it like, I'm asking, I mean, of course, you have an option of introducing, so this has come straight away from third line to second line. And if you find a brain metastasis, would you still use a pertuzumab, and would you consider bringing it upfront, or
yeah, definitely better drug if it is available and I can use it upfront, so that will help. But still, so current practices that we
so
are not
could it be
doing
moved into first line? I mean, I'm
yeah,
jumping the gun.
Whatever the
Yeah.
results that are shown are very excellent. Means even if you see PFS, when if you see CRs, so that is very important. CR rates are quite significant. They are almost 30% CR rates, and then why not?
Right.
So that might be one of the option in the future, but current practices are.
So Dr. Chaturbhuj, your thoughts?
Sorry, sir. Can you repeat the question, please?
So what I'm asking is that has time come, and probably you are there with these drugs might be available to you where you are. So with tucatinib and TDX being there for you, would you now screen for brain metastasis in a MBC HER2 new? Let's say you have an option of TDM1 and TDX in a second line post trastuzumab progression.
So I think the data for trastuzumab deruxtecan, to me, it looks very, very much convincing. But the only problem I find is that we don't have any evidence that once we use trastuzumab deruxtecan, then what we are going to use next. So if we use TDM1, post TDM1 trastuzumab deruxtecan, yes, we can use. But post trastuzumab deruxtecan, we don't know what we are going to use. For patients who fail in brain, I think we can use tucatinib. So this is, but yes, indeed, it's a very good molecule.
It's a very important point that you made, that if you use your efficacious molecule earlier, you probably are thinking hard to what would you use next. So that's a very important point. The next point is that what would you treat an asymptomatic brain metastasis, which is non-critical, with systemic therapy first? And may I ask this to Dr. Abhishek?
Yeah, I think if the patient is asymptomatic, of course, local or regional therapy is not required. A systemic therapy, if the patient is having HER2 positive, then we have to give systemic therapy in the form of anti-HER2 therapy.
So with your current practice, let's say on a PET CT, you find there is a frontal lobe lesion, and this is non-critical, and mild edema is there. So would you start this patient, and this patient is a progressor on trastuzumab, and less than 6 months, or early progressor, let's say post-adjuvant. Would you start TDM1 over here without considering radiation?
No, I do take consideration of radiation, because the TDM being a larger molecule, it's difficult to cross the blood-brain barrier. So we have to take the opinion of radiation oncologist here as well. And
okay, so if I may put this to Dr. Amitabh. Dr. Amitabh Upadhyay is there with us?
No, sir.
He was there. Okay, right. So I would then put this to Dr. Prasad, and then to
my
Dr.
practice is that I treat with radiation and continue systemic therapy. And this has been there before TDM1 came, when we had limited options. But definitely, my present practice involves in giving radiation to asymptomatic brain mets in HER2 positive breast cancer.
Right. Now, why I'm asking this is because there were patients in Camilla trial actually who were untreated, and they were actually, they were responding as well as the treated ones, with quite a similar response rates of quite a comparable response rates, with quite a similar clinical benefit and a median PFS, of course. So that's why I asked this question, that in such a scenario, does Camilla trial come to your mind, or as you just said, that you would definitely consider radiation. Dr. Kshitij, what's your thought?
So if you ask me current practices, then if it is a very small lesion, asymptomatic, then with the availability of this lapatinib, we usually caplab is the option that we're using very commonly. And with the availability of this proper deruxtecan, and definitely we can consider using that thing without treating with the whole brain RTA. But with TDM1, little doubt.
So somehow the trial did not take over here. If we look at the trial design, it has taken patients which have been treated, probably just sort of played safe over here. Though tucatinib trial, actually the HER2 climb did take into account some 60 odd patients who weren't treated, and they were taken into straight away for systemic therapy. So these were the intracranial responses for TDXT, and great responses, even CRs happening, nearly 27% good PRs happening. So does this change your practice with, of course, again, the availability of the drug? Does this paradigm change for you if the drug is available, or whichever basis? I mean, does this happen to change after ESMO 21 TDXT in the second line and TDM1 pushed to the third line, or probably post used in adjuvant earlier, then it would have that place?
Can I take that question?
Yeah.
I think if you ask based on available data, I think second line is now fixed with TDXT, because there you can't have a better outcome than this in terms of a trial data. But in our practice, I think this will still continue, because we are seeking the availability of I was searching for an availability of TDXT trial for a patient who has failed other options, and now we don't have that trial option only. It has gone to first line. All the ongoing trials in the country are in the first line setting. So our practice will continue to use multiple anti-HER2 therapies, but as a standard of care, if it's available, I think it's a straightforward choice. And one option, if you have brain metastasis, maybe giving tucatinib. I think Bharat has put a message in the chat box. I think that is something which can be discussed about tucatinib as a earlier than giving TDXT and keeping it for later option. Maybe that somebody else can comment on that.
Yeah, Dr. Kshitij, would you change your practice towards this particular paradigm?
Yeah, I agree with Dr. Prasad, but the data of this trial is so excellent. Definitely, we would like to change. If the drug is available, definitely second line.
Definitely, we would like to change. Okay. So I think so. The rest of my panelists would also agree to the same, that definitely if the drug is available, TDXT does come into second line, probably is now going to fight for the first line rather. It looks like that. And I agree that the tucatinib could also be used earlier with the Compass RD sort of trial going on, what Dr. Prasad just mentioned. I think so. That sort of trial would also be impressive, bringing tucatinib up front. Now, are you concerned about ILD? Because another thing is in Destiny Breast 1, which was the phase 2, there were 4 deaths. And they were happening actually at any time, though for the 4 months was the most common time that the ILD was actually happening, but it could happen up to 8 months as well. So here, but in this particular trial, what Dr. Shefali just presented, and she said that not too many patients had ILD of a very significant grade, but it was there in the previous phase 2 early study. So what do you feel that, is it like keeping this drug for late post TDM1 could cause this, or I mean, why was this that there aren't any grade 3 or 4 toxicities over here? Dr. Amitabh or Dr. Chaturbuj?
So Dr. Amitabh has not joined the panel.
Okay, so Dr. Abhishek.
So it's very difficult to predict because there are no grade 4 or grade 5 ILT in this trial, and only all the ILT were of easily manageable grade 1, 2, and 3. So it's very difficult to say that whether it is because of prolonged exposure of TDM1 or something else. It's very difficult to say, I think.
Dr. Chaturvedi, your thoughts, keeping a drug like this, and of course TDM1 is also known to cause ILD?
So what I think in practically what we have seen that ILD is sometimes an issue. So TDM1, with TDM1, we have seen one death related to ILD related to TDM1. Particularly in patients who have got pulmonary metastasis, it's very difficult to attribute ILD. It is due to TDM1. Second thing with trastuzumab deruxtecan, I think 17%, if I'm not wrong, somebody can correct me if I'm wrong, 17% ILD is reported. So that is again very much matter of concern. Patients are same. I would see if patient has got pulmonary metastasis, if patient is frail, if patient has got other risk factors like smoking, he's a COPD, then definitely I would sort of tend to avoid these drugs. But if patient is absolutely fine, pulmonary conditions are great, then probably I would choose TDM1 or trastuzumab deruxtecan.
Right. So that's what we were discussing, that none of the high-grade ILDs were reported over here. So probably some reason that this trial is, this trial is not having those ILDs. We probably would get to know down the line. So the second trial, the abstract which was discussed was LSS strand, and this is a SERD, oral SERD, and we saw that this is actually positioned after CDK4/6. What was discussed, that this is a area of need, and this is this being an oral drug, and was pitched against fulvestrant, was there in the investigator choice treatment along with the other AIs. And the co-primary endpoints were PFS in all patients. And over here, one subset was ESR1 population, where the PFS was looked at. And what was found that in the ESR1 population, and of course the all comers as well, there was a good PFS. And the ESR1 was doing pretty well. So that's a difficult subgroup, as the presenter rightly just mentioned, that this is a difficult subgroup to treat. My question is that, of course, the survival, overall survival was also looking better. So your agent of choice, and this is to Dr. Prasad, in which setting fulvestrant alone in today's date are you using, if in case you have to use the Falcon setting?
I think mostly we have moved to CDK4/6 combinations in my practice, but there are a few patients maybe fulvestrant alone, but there is nothing to say that they will not benefit by CDK4/6 inhibition. But fulvestrant, I think one of the biggest challenges is the intramuscular dosing and the pain which is associated with that. So this drug is definitely welcome, and if it is available, I think it will be practice changing.
So, so what I was actually trying to ask is, and you said that, I mean, you have moved towards a combination practice of CDK4/6. What I was trying to ask is, it becomes tough for me, and there were a couple of patients where I had to, think that really after I had given in an oligometastatic scenario, fulvestrant only bone metastasis, exquisite hormonal sensitivity was there. And alone after fulvestrant failure, I actually introduced CDK4/6, and then thereafter, post failure with the AI and CDK4/6, I was just thinking, what partner would I choose for future therapies? Pick 3CA if in case it comes positive. So probably that that sort of flow chart is getting blurred if in case we are using fulvestrant alone right now. Probably with this molecule, there might be some help. So if I may ask, Dr. Kshitij, let's say you have a PIK3CA negative. What currently are you using post failure of the combination?
Okay, so you want to ask about the letrozole plus, suppose, CDK4 inhibitor and progression over
has
that
been used, and
yeah.
You have a progression at hand, and PIK3CA is you cannot use alpelisib right now. What
Okay,
are you commonly using? I mean,
yeah. So and
everolimus.
it is not a disease is not like causing this which requirement for chemotherapy. Then my usually I'm using fulvestrant and sometimes everolimus plus exemestane, and
So-
if required, the indication is then chemo.
Right. So everolimus somewhere comes in the combination in your practice, and is the time right now to start checking for biomarkers, Dr. Kshitij? Time for NGS once you get
Yeah, so in breast actually we are doing it much less, but we are commonly doing PIK3CA mutation, but we have tried once or twice, but at that time we did not find any meaningful mutations in that.
So, I mean, with the sort of drug now coming up, the Emerald trial, do you think, and may I ask Dr. Chaturbhuj and Dr. Abhishek to pitch in, with the sort of drug coming up, do you think that NGS would get important?
I don't think so. See, NGS we used to do more in triple negative, and in this subset, particularly, first to answer that question, that patient has progressed on CDK inhibitor and aromatase inhibitors, and now what next? If PIK3CA is, agree with Dr. Kshitij what he told, fulvestrant or everolimus plus exemestane. But one more thing, there is a few subset of patients in which I have used fulvestrant plus everolimus. We have a phase 2 data for that. So now, because sometimes, you're really bothered that we can use the hormonal therapy now, and then probably we will be forced to use chemotherapy in the next line. So then in those scenarios, I will use fulvestrant plus everolimus, and I will not hold everolimus for the third line. That is one thing. Second thing, NGS, if you talk of NGS,
so
we can obviously,
please answer your second question in context that you have availability of these drugs, the ones presented.
So this drug,
Yes.
I think the data is emerging. We have an early data, but the data will emerge if we start doing NGS and if we start using these drugs. Because long time back, I don't think we have a data for fulvestrant plus everolimus, but when we start using it, we realize that yes, it's also a good combination. Maybe we need a phase 3 trial to prove it. So obviously NGS must be done, but the hard point is in hormone positive cancers, practically I have seen very less number of mutations coming up in NGS apart from PIK3C and ESR1. But even if we find ESR, there is no evidence that we change the aromatase inhibitor to fulvestrant and continue with CDK. I don't think that evidence is still lacking. So NGS we can do, but the chances of getting a benefit from NGS are very little.
You rightly said for
mutations,
Dr. Abhishek.
hormone receptor positive breast cancer in this setting are very less. Apart from PIK3 and ESR1, I don't think there are any actual mutation presently for the hormone receptor positive breast cancer. And after the progression on a CDK4/6 inhibitor, we have to do the PIK3 mutation. And after alpelisib, we have given, then the options only remains everolimus, exemestane, or we can start with the chemotherapeutics.
So why I'm asking is actually, with the sort of data which was presented, and there were two drugs which were presented. One was this oral SERD, where definitely ESR1 is the population which was getting benefited. And again, the samuracyclib, where there was a TP53 mutation, where if it was mutant, I mean, now that drug also has gained a fast track approval. So if this is available to you, I think so somewhere NGS is probably trying to creep in. I'm not saying this, yes, in current practice. Of course, I agree that for right now, it's all comers. We just give, and with the sort of BILEAV data, either you use fulvestrant or letrozole, really wouldn't matter, whatever your partner would be. And everolimus also, whatever combination you use might not really matter. But this is creeping in actually. And there is data to say that if we look at the tissue mutations, ESR1 is somewhere around, quite a variable frequency from anywhere between 0.9 to 8%. And once post-treatment of AI, so it increases up to 30%, especially if in case we look at the circulating tumor DNA, because this is a subclonal sort of mutation, and this definitely increases. This is what I was trying to cover, and this TP53 mutation again, with semuracycline not working in the mutant type, probably would be the way to actually position this drug. And these were the results. So I think so with the sort of results available, I would conclude the panel over here and would say that probably we have concluded today that TDX1 definitely is replacing TDM1 if it's available to us. Yes. And if I'm not wrong, and if the panel agrees, is the time, NGS might start creeping in with these drugs, new drugs available to us, and we would start doing NGS as well in this particular subset, where we weren't doing it. Probably triple negative is the one where we were thinking about it. Does the panel agree on that?
Okay.
Yes.
Yeah. I think that's fair.
Thank you. Thank you very much. And thanks to my panelists. And I
Thank you,
just
everyone.
run back to Dr. Rajat. Thank you.
Thank you.
Thank you. Yes, thank you, Dr. Vajpayee, sir, and all the panelists for such an interactive panel discussion, and certainly a lot of takeaways that we all had with this panel discussion. Thank you very much. So now we come to the last part of our session, this day 2, and last but not the least, we have two experts who are going to tell us in this SABCS, and hello, am I audible?
Rajat, either you are not in network or I am not in network. One of us is not.
No, I think I am not in network. Now am I audible?
Yeah, you are.
Yes. Sorry, I think there was a connection error. So what I was talking is that we have two experts with us who are well known in their fields and who are going to talk us through what are their thoughts on the new trials which have been presented and how do they look a senior consultant in Silver Line Hospital, Bhopal, and Dr. Bharat Vaswani is working as a senior consultant in Yashoda Hospital, Secunderabad. Sir, good evening, both of you, and we are happy to have you. Can we start the discussion?
Yeah, sure. Bharat, you're there?
So, sir, the first...
Bharat is there, Rajat?
Yes, sir, I saw him. I'll just...
Yeah. That's okay. So let's start. I saw him, but...
Yeah. So the first trial that we are going to discuss is what we've been discussing for the last half an hour. A lot of talk about Destiny 03. So I think one of the very practice-changing studies that we have had in this SABCS. So what is your take on it? Is trastuzumab deruxtecan a game changer in HER2-positive metastatic breast cancer? Can we say it is the Destiny's child?
Yeah, if it is pointed to me, I would tell that definitely this is one of the trials which has shown a tremendous hazards, which you have seen, I think so, when we saw Adura in lung and other things. That's how it is all about now. And I think it is going to change the landscape of treatment of HER2 breast cancer. And the most beauty of this trial has been not only the hazards on the PFS, it is the response which it has on the intracranial response. And that's something that will be point that is in its favor. The point of the pneumonitis is something which I think this trial has made us reassured that if it is not with the pre-treatment with TDM1, probably the pneumonitis is there to 10%, but it is only grade 1 and grade 2. You would find even grade 3 less than 1%. Grade 4, grade 5 is 0. So I think this is a very reassuring trial. And if the drug is available, if the pocket is deep, I would not hesitate to give this drug.
Okay, so sir, do you agree that although these are robust findings, a very impressive hazard ratio, as you said, we've seen that in LX study, Adora study, but I think with breast it has come after a long time. But then there is a little criticism saying that the overall survival has not come, and should we really jump the gun, or should we really say that the writing is on the wall, and certainly trastuzumab deruxtecan is there to be in the second line as compared to TDM1? Can we say it as yet, or should we wait for the overall survival results to come?
I think I will. Yeah, please, Bharat.
Sir, you can answer, please, sir. I'll pitch in later.
No, Bharat, please pitch in.
No, sir, you can start, please.
Okay. So I feel the hazards of 0.28 really impresses me. And and this should show a survival benefit. If this does not, it would be something which we need to then relook at how we look at the trials. But if I look at a metastatic disease scenario, PFS is something which I will take it as an endpoint, because this PFS is a very important endpoint, and OS would be the endpoint which we have lived with as medical oncologist students being a medical oncology. But I will definitely put my money in this bag that this will be a positive trial in regards to the survival. And it's very difficult to believe that it will be a negative trial in any way. The response rates are greater, the intracranial response rates are good, the toxicity is tolerable, and you have a PFS in all patient population which is looking to be 0.28. And the last part is the brain metastasis and no metastasis, they both look similar. So everything put together, it's a nice drug to have it in your basket. Bharat.
Agreed. Everything. Look, this drug is more potent than TDM1. That is something that we need to understand and remember. It is an active payload, which is 7 to 8. It is a cleavable linker. So all in all, this is a potent drug. Now, 0.28 against a standard of care, which was a TDM1, can never be achieved. We discussed about Adora, which was a placebo. Please remember, this is against the standard of care, and getting a 72% improvement or a reduction in the risk of progression is something that we never thought of. Everybody believes that this will be positive, but the quantum of benefit is nearly 2 to 3 times more. So 75% of the patient doing well at 12 months. In patient who had 0 to 1 chemo, if you see that, it was 22 months is a PFS. In fact, it was better than the first line treatment of trastuzumab and pertuzumab, which was 18 months. If you look into the subset analysis, 0 to 1 had 22 months. So down the line, you will see this data probably being compared in the first line in a phase 3, and you might have this more active drug coming in the earlier line also. Now, there was one question which was put up: what about TDM1 if you given in the second line? What about the third line? So there is nothing to believe that tucatinib or TDM1, if given in the later line, will not work. Please remember. So that is something, and we always believe that the active drug should come earlier. That is it. You should give your best drug upfront. So what sir said, ORR 80%, DFS of disease control of nearly 97%, PFS, which is hazard ratio of 0.28, intracranial 60 to 70% response, disease control 80%, 27% CR. You can have never thought a drug could be as good as what trastuzumab deruxtecan is. More importantly, toxicity, only 2 patients grade 3 and 4 interstitial lung disease toxicity. So probably over a period of time, once we get the drug, we will know probably when to stop the drug also, or when we should start with the support care. So probably I don't think so there is any confusion now, and even NCCN has adopted it now. If you see, it is a preferred second line now as per as NCCN guidelines.
Yes, so I completely agree. There is one point that I have in mind, and I would like to ask both of you. So we saw that in FLORA study, in osimertinib in metastatic lung in EGFR mutated, we had 2 results. One was that if patients had baseline metastasis in the brain, then there was a reduction in the brain metastasis. But if the patient did not have baseline metastasis in the brain, that the time to intracranial progression also was reduced or was advanced with osimertinib. Now we don't have the data for patients who do not have brain metastasis upfront for the trastuzumab deruxtecan in the DESTINY-03 study. So suppose tomorrow we have a patient who is progressed on pertuzumab, trastuzumab and docetaxel and is now warranting a second line therapy, and the patient does not have brain metastasis at present. So, and we also know for a fact that we have Destiny Breast 01 where even post multiple lines, trastuzumab deruxtecan has shown impressive intracranial responses. In this patient may not have brain mets at this moment, but will develop brain metastasis in coming few months or maybe a year down the line. So in this patient also, in a patient who is warranting a second line therapy, not having brain metastasis as of now, would you still like to use deruxtecan over TDM1, or would you like to use deruxtecan in this patient in the later lines of therapy? Dr. Vaswani followed by Dr. Sahu.
Look, if you want, we could have a cross trial comparison if you want. Now, when you look into the data of TDM1 in brain mets or de novo, it penetrates brain. We know it is better than lapatinib as per as Camellia study, what was discussed by Piyush. But all in all, what we know is that deruxtecan has a good intracranial activity. That is something, and it is better than TDM1. Now, when you look into the subset analysis also, it was 15 months. Now, this 15 months could again never be achieved by any of the things. If you look into TDM1 study, if you look into the normal PFS also in Emilia or Tyresa study, it is not more than 6 to 10 months is the thing. Now you are having a drug whose PFS privilege is 15 months. That is something which is, so there is absolutely no comparison at all when we are discussing. This is a more effective drug. It has a better CNS penetration. And even if you should not do a cross-trial comparison, its PFS is much, even twice, I can say, for those when you have a cross-trial comparison with the Camellia study. Now, will it prevent brain mets progression? The answer is again yes. Now, when you look into the subset analysis of TDX, 16% were baseline and overall there were 25% only. And when you look to the other time, it was much more than that. So for me, brain mets, no brain mets. If I have to compare with TDM1, there is only one answer. I had a discussion with Sahu sir on chat box. What about tucatinib? That is something sir said. No, that I said we can always debate it because only one scenario where I may think of giving tucatinib in the second line. It has already been approved post first line if you say the FDA approval is there. But I may have size preference being an oral tablet with a very impressive fifth line data with a PFS of 7.2, very good intracranial. Maybe if you can get this drug in the second line, you might have this 15 months of PFS also. So that might be one of the debates. With TDM1, no debate. TDXT is the drug without brain met. Far impressive data, even in the intracranial control, nearly twice the PFS. Sahu sir, I want you to
yeah, sure. I just wanted to add one data which people I don't know have is in the brain response. If you look at the slide very carefully, look at the progression of disease data which is there in the intracranial response. You have only a 2% progression of disease with the deruxtecan versus around 20% progression in the TDM1. So does it not give a data on the activity that it will definitely decrease, and it definitely decreases the chance of new formation in the brain? So I think that is the data which is very directly there. And that data, I think, should be put in perspective. The progression of disease is 2 versus 20%. So all said and done, if I can answer your question, if I can look into the future, I would like to predict that yes, I probably am looking at a drug which is not only active intracranially, but most likely would also produce a data which, to that aspect, we have some data very clearly that the progression in the brain is at least only 10% of that of TDM1. So that is an indication that it might prevent new formation of brain mets. I think that data is strong enough to do that. About the tucatinib, I feel that I have a reservation for that. Why I'm telling you, till this Destiny 03 was there, all of us believed that if you have a brain mets post first line progression, tucatinib is the way to go forward, because TDM1, which was the available agent, was not active into that respect of tucatinib. But to be fair to the Hercline, and if you compare with Destiny, there are two major differences which I want to point out, and I think all of us can discuss what should be the way forward. The first point which I want to point out is Destiny 03 is one line failed, 100% received trastuzumab, and 60% have received pertuzumab. But while Hercline is at least 2 lines of failure, where people have in the third line and have failed a TDM1 and a trastuzumab. So and that is one very important point which I want to point out. Second, across trials, if we look at the intracranial response rates with tucatinib, because it has been with us before and we know it is intracranially active, it is a response rate of around 30 to 40%, if I'm not wrong, if my memory holds right. We are getting a much higher response rate with the deruxtecan drug. So in that respect, I'll be very comfortable if I have a patient with brain mets to give a deruxtecan as a front line and then keep tucatinib on progression. So I feel I made my points clear because I have data to the first line failure here, where Hercline is the 2-line failure. And I have data now that in the response rate intracranially is superior for TDA deruxtecan than the tucatinib. I think that makes a point.
The only debate is we cannot. Second line of a less treated patient. If you see tucatinib, the guideline was more than 2, but median 4 lines were treated. So whatever that data was, 7.21 was mostly in 5th line.
So Bharat, that gives me a confidence that if I push tucatinib to down the line, it is still active. So why not give a more responsive agent?
Which is being explored now is TDXT or TDM1. What does tucatinib do is basically tucatinib increases the expression of HER2/neu. So that is the thing. So the best data with TDM1 or whatever is when they have given post tucatinib also. So probably that concept is now coming up in a big way that post tucatinib these drugs might even work better. Although absolutely beyond the discussion, I agree with sir that at this moment the earlier data, impressive data. My point was just to put a debate that we have an oral tablet available probably and has a good CNS. Agreed with what sir said. Fully agree.
Right. So I think both the points are very valid, and in times to come, we'll have more data as to how to sequence both these drugs which are available or shall be made available to us. As of now, the drugs are not available. So before I move on to the next topic, can I just ask both my experts as to if we have to choose from the drugs which are available, are we as of now doing Perjeta based therapy in the first line followed by TDM1 in the second line? Do both my experts agree with this?
First line, yes sir. First line trastuzumab, pertuzumab, because there is no first line data. And second line, whenever it is available, trastuzumab, deruxtecan. I'll put my TDM1 maybe in the 4th line whenever because at this present we don't have a drug available. So what is going on is going on, but deruxtecan is available.
I get your question, Rajat. It is on this present scenario what we do, and I think you have put it very rightly that you do give trastuzumab, and I think very less percentage of our patients ever receive pertuzumab just because it's too prohibitive as a cost wise. So, and then the second line comes down to TDM1. Now with the generic coming, it's probably okay. But most of the patient also receive a lapatinib combination with the capecitabine. That's also there. So that is how I put it across, and money does play a major role how I decide my treatment at this point.
Okay, so just one last point on this, and then we move to Keynote 522. is that suppose a patient has taken Herceptin plus paclitaxel in the first line, has had a progression after say about 12 months, and again chooses to take Herceptin now with gemcitabine and carboplatin, and then the third line has been eribulin plus trastuzumab. So this is an actual scenario that had come to me. After eribulin plus trastuzumab with a PFS of say about 4 to 6 months, is it right to tell this patient that you have the option of TDM1 available, or would we not like to give TDM1 to this patient? So he has had paclitaxel plus trastuzumab, gemcar plus trastuzumab, and eribulin plus trastuzumab, and now in the fourth line with a good performance status, do we expect the TDM1 to work in this patient? A real life scenario.
Bharat, please.
Actually, we have a data to support this. You had two pivotal studies of TDM1. One was the Emilia, which was a purely second line study, and then was a Tyresa study, TYTH3PERA. That was a study which was done in the later lines. And we have enough data to suggest that TDM1, either given in a second line or in the later line after trastuzumab, retains the activity with an impressive PFS of close to 6 months and the OS of close to 18 to 20 months. So I'll give it, sir. Whenever a patient, now which we have a generic available also, whenever it is available or a patient can afford it, I'll go to TDM1 as my next preferred option. Sir, you can add on.
Agreed.
Okay, right. So now we move ahead and we talk about the Keynote 522 study. So this study has been talked about a lot in early triple negative breast cancer. So after coming in of this Keynote 522, and we also know that there are similar studies which have been floating around Keynote 522 with the use of durvalumab in the neoadjuvant setting, and also with the use of the other immunotherapy in the neoadjuvant setting. Passion 031, yes, and the durvalumab study. So can I ask my experts as to whether these studies around you have made you a fan of immunotherapy in the neoadjuvant setting in triple negative just as yet, or would you like more data to come in? Starting with Dr. Sahu sir and then Dr. Vaswani.
I think the 522 did make a headway and has made our heads change towards it in a positive way. And I would put it across that if I look at the way how we treat, first, when we started off with adjuvant treatment for all breast cancers. So to feel convinced about taking the neoadjuvant approach took some years for us. And now most of us do believe that if I have a neoadjuvant approach, I would be able to tailor my adjuvant therapy depending upon the PAT-CR. And TaylorX did make me first change the things, and people started taking the triple negative. Most of the patients should go for a neoadjuvant because I have something to add to that survival. While in ER positive, I still go for surgery upfront because I have data to do some adjuvant CDK4/6 even in the later in the adjuvant therapies. What 522 has done is brightness came along with that it did have carboplatin, and we know now carboplatin in the neoadjuvant scenario is advantageous in the triple negative group irrespective of the BRCA mutations. And this data again proves you that if you add immunotherapy irrespective and the platinum is anyway there, you still get the added advantage of the PAT-CR and the EFS. If those two data are positive, and the Durva trial which you told, although the PAT-CR data was not impressive, but the event-free survival was impressive. So what I mean to say is, if the event-free survival is impressive, and now with the 522, I have a definite data that the PAT-CRs are impressive. And one more data that has impressed me in the 522, I would like to see one more trial duplicated is in the PD-L1 negative group. Actually, the quantum of benefit was more of addition of the pembrolizumab. So I feel that 522 is probably practice changing. If one more trial confirms the data in the lines of 522, then all of us will be pretty assured because this is a costly drug. And lastly, what I want to tell is if I can achieve a PAT-CR, I'll always work towards achieving a PAT-CR because if I'm doing neoadjuvant, that is one of my major endpoints. The other endpoint being the event-free survival. So I am pretty okay, and I think in affordable case, I will be discussing two things which I never used to do. First, add carboplatin to my neoadjuvant protocol, which I never used to do till now. And second, definitely discuss about the addition of pembrolizumab, but platinum for sure, because it does not cost me anything. But I will discuss the immune checkpoints. Well,
Okay. Dr. Vaswani.
Perfect. Everything you summarized was excellent. We had proved two primary endpoint of 522. One was PET CR. So 68 to 69% PET CR never has been achieved. So good. So, and the quantum of benefit is 15 to 20% more patients have a pathological CR. So invariably that is a surrogate marker for OS. So 15 to 20% patients who do further better. Now, event-free survival, again, when you look at 3 years, the quantum of benefit is quite huge, around 8 to 8.5% event-free survival benefit at 3 years. And we know that immunotherapy over a long term, you always look at the tail of the curve. And you have already achieved that difference. So probably we will definitely get a OS advantage. Now, sir added on one more point of carbo. Fully agreed with what that brightness has proved that, again, the one study that you can put it now that includes, and you can include platinum here, is definitely agree. Now problem comes is cost factor, and absolutely agree. So the concept that is you give a neoadjuvant, probably when you get a PET CR, how much pembro adds on in the post-operative setting, nobody knows, because you have arrived to that point where with 8 doses, you have got to the point where you achieve. So probably in that 32% patient, we did not achieve a PET CR. Probably that is a thing, because once you have achieved a PET CR, and when you know the long surrogate 5 years at other is very good. So probably can we stop pembro at that point? That is something that future studies should look into it, because our main PET, we have got it and we know that it will work well if you have got a PET CR. So can you avoid that after 8 doses whenever you have to complete yearly? Or probably when you don't have a PET CR, giving only pembro or combining pembro with capecitabine, maybe that would be a way to go, whether you can give both of these drugs and can you get an incremental benefit. But 522, fully agreed with what sir said. I did many more points. It is a practice changing abstract. If your patient can afford it, I think everybody should give this option to the patient.
Yes. Okay. So points very well taken by both the experts. So there are a few points in my mind regarding 522 which I would like to clear. One is that about 20 to 22% of patients were not able to continue with the therapy, and they had to discontinue because of the adverse events. That is one point. The other point is that they did not take into consideration the BRCA mutation status, which in 2022 in triple negative breast cancer we do select our patients based on the BRCA mutation, and I'm referring to the Olympia study. And then the third point is that can we really in BRCA mutated patients combine pembro plus Olympia in the adjuvant setting, like Dr. Vaswani just said, combination of capecitabine plus pembro in the adjuvant setting. So what are your points? Suppose we have a patient who has a BRCA mutation status positive on a Monday morning. Would we like to offer this patient a 522 or an Olympia is something that I would like to know. And along with the adverse effect profile, because 1/5 of the patients discontinued. Dr. Sahu sir, followed by Dr. Vaswani.
See, for first thing is, I think one trial would not be able to answer a lot of these questions. But if I think put in perspective, if I have a BRCA positive patient, I would still go ahead and give the platinum and the immune checkpoints to the patient. And if the patient does achieve a PET CR, which is very likely in the tune of 60-70%, then I agree with Bharat that I would not be probably offering the patient any further adjuvant treatment, and then would be going for radiotherapy if that is the scenario case in contention, and then going for the option of olaparib. So that I think are something. But if that is not, my only point I always want, because in the chat box in our groups we always get that if a patient has received a neoadjuvant, has residual disease, is BRCA positive, should I be doing capecitabine, or should I be doing both olaparib and capecitabine, or should I be doing only olaparib? What I always feel is, why not go for 4 months of capecitabine and then go for olaparib after that for 1 year? I think I will take that approach into mind and give a olaparib beyond 4 months And is there any data to that perspective that if you delay the olaparib, if after capecitabine it is not beneficial? I feel there is no data to that. So I will try to give the maximum benefit. I will definitely take the neoadjuvant approach, because if I achieve a PAT-CR, then olaparib directly comes into the contention after my treatment is over, and that will happen more likely and will only not happen in 20%. About the point of people not able to complete, if you look at the comparator arm of the non-immune checkpoint, also only chemotherapy, there were also around around more than 10% patients who could not complete the protocol as per schedule. So I think that does make a contention that people with platinum especially, I feel people have issues with tolerability. All of us know that. And did platinum addition play to that intolerability and non-completion was little high is a question all of us need to answer. That's one point. I don't know we have data to that, but I always feel if you add Pacli carbo versus only Pacli, I think the Pacli carbo tolerability is always poorer. And that's one point which I think Bharat can add on to what I thought.
Agree. What sir said is on a Monday morning, I'll start with my 522 protocol, because the very fact is 68% achieve the pathological CR. So you don't think of giving any adjuvant. So capecitabine is already out because that data is over. Now I'll put one more question to tell. Suppose I have a residual disease and I have to choose between a olaparib or a capecitabine. I have to choose one. I'm not telling both. What sir said is absolutely best. This is called as TP South at the very best. Absolutely right. Now, which is a better drug than capecitabine? That is something I have heard lot of time that capecitabine was not given because at that time that was not a standard of care. Please remember, I am going towards your Olympiad study. I am cross-relating from your metastatic. If you look into the Olympiad, which was a metastatic disease, the other comparator arm in 45% was capecitabine. So what we know as per as Olympiad study that olaparib works better than capecitabine. Please, that is, if you have time, go through the full text NEJM article of Olympia study. What they have suggested is that Foster et al., who has done that trial, they suggest that in a metastatic setting, olaparib was better than capecitabine because 45% of the patient in the other arm took capecitabine. So if you have because I read it in the morning today only. So what they say is definitely it will work better than capecitabine whenever you have given, although a cross trial thing and we should be careful about.
No,
so if
Bharat. Yeah, sure.
So what I want to say is, given a choice to me on a Monday morning, if there is a residual disease, I'll take my olaparib as 1 year. Probably if I've given both these drugs, I'll take it because I probably from a metastatic setting, I know that will be better than capecitabine. Now, again, if you have to compare we have a 5-year data there and we have a 3 years, and this data is also impressive. Around 80 to 85%. So the thing is, maybe at 5 years, if we can do a cross trial comparison. But for me, if given a chance, if my patient can afford, olaparib is not such a bad drug because the drug discontinuation was only 9 to 10%. The hematological toxicity, 8.3% anemia and some GI toxicity. So probably that is not as bad as it is thought to be tolerated. For me, what sir said, keynote 522 is a way to go. In a post-op setting, if I have to give in terms of residual disease, I'll think of olaparib. Maybe both are equal. Again, I'm doing a cross trial, but that is what we have. And we have to take out some points from the trial that is present at present. Sir, please.
No. I think Bharat made a very clear point that in the Olympia, the data was that if someone does not achieve a PAT-CR and has residual disease post-neoadjuvant treatment, the patient goes for a olaparib after the radiotherapy is over, and that makes sense. And if you look at the patients, I was coming to a different point altogether. If the olaparib could be started after completion of adjuvant chemotherapy also. That is also there for patients who took adjuvant. So I was making the point that you have to start olaparib within 1 month or just after completion of RT. Means that what I wanted to make a point, if you look at the thing that olaparib after 6 months or 4 months of adjuvant chemotherapy was still found to be effective. So if someone really believed in the Createx data and wanted to give the additional benefit, so that is the point which I wanted to make, that a delay of starting of olaparib beyond 4 months or 5 months of surgery has not hampered the data of survival or the benefit which Olympia has shown. That is the only point I wanted to make. But what Bharat has told actually is the copybook style of what the trial was designed for. And I totally take his point. And if I have to choose one of the agents, it will be a PARP inhibitor, because I have a target, I have the inhibitor, I will always take it.
My apologies, sir. You need to conclude your sessions because time is like 1 minute left for that. Yeah.
Yes.
Excellent.
So this I think space is still needs to be discussed more, and a very nice discussion. So we come to the last part of our discussion now, and I would like to ask my experts as to what are your comments on the second line therapy in HR positive HER2 negative metastatic breast cancer post CDK4/6 inhibition, with the space now having more drugs, with a new drug oral third inhibitor which is called elacestrant coming into the picture. What do you think how the role is going to be in the coming times? Dr. Vaswani sir, followed by Dr. Sahu.
Excellent. Actually, the thing is, there was some the panel discussion. Look, ESR1 doesn't tell me that I should give elacestrant. Please remember, there are two trials now, Emerald also, and before that there was a phase 2 trial of Veronica study. That was a trial which basically included venetoclax, but there was a single arm of fulvestrant. In both of these studies, what we know is fulvestrant does not work well post CDK4/6 inhibitor. In both these studies, if you see the Emerald study also, the PFS in both the studies is less than 2 months. So what we know is that fulvestrant may not be such a good drug. Maybe that is the only option we have. That is different. If pick 3, we always keep on including with BiLeave. But a single agent fulvestrant post CDK and 4/6 inhibitor in 2 of the studies have shown the PF of less than 2 months. So the thing is, should we start doing a ESR? Probably when elacestrant will be available, you don't need to, because please remember 30% improvement with or without ESR1 mutation, 45% relative risk of reduction when you have a ESR1 mutation. So that does tell you that once you have this mutation, your quantum of benefit is more. But irrespective of the mutation, the elacestrant is a better drug. So on a Monday morning, whenever this drug comes, I will use this drug, irrespective whether you do a ESR. That is more important for AI, not for CDK4/6. So the discussion always goes to that, but that is not relevant here also. Now the thing is, this field will be congested. In the next 5 years, there are 10 drugs which are coming up in this field. elacestrant is one of the 9 SERDs which are coming up here. Now the time will come where you will include SERDs in the first line. So we have a trial which is combining with palbociclib, a trial which is combining with AI, and a trial which is combining the 3C. So we have, this field is not, and second line now, it will first line also, you will see the drugs might combine with CDK4/6 with a SERD rather than an AI. These data are also wrong. If somebody, now there is a very good presentation in peer review that 10 days back only, Amira study that is combining palbociclib with a SERD. So we are going into that exciting era where we will have drugs which are more potent than fulvestrant, we know, but we will have these drugs more in the first line. Second line is crowded, but the same thing what we have discussed about trastuzumab deruxtecan, and the same thing holds for SERDs also. This drug is least toxic. If you see the toxicity, it is as good or as same as fulvestrant, less than 10%, and only some GI toxicity. So these are safer drugs, yes. These are more potent drugs, yes. So probably in future, you might get these drugs in the first line along with, you may have both 3, you may have 2, or you may combine it with the 2. So yes, I believe we will have a lot of new drugs. We have already started getting it, and this is the first phase 3 data coming. But in the next 4 or 5 years, with the data coming up, you will have a lot of new options available, and probably fulvestrant may not be one of them, because you might have more. We already have one drug, and you might have more drugs in the future. South, sir, you may add on.
Yeah, sure. I think this is the last question where I little differ from Bharat in 2-3 points. Otherwise, I totally agreed on both the trials. Point number 1, if you look at the Emerald study, I look at it in a little differently. Although I agree that the PFS was statistically significant for all patients and for patients with mutation of ESR1 positive, but the hazards were significantly more in favor. And if you look at the absolute values of PFS, it was actually 1 month more in the mutation patients. The point number 2, I'm pretty not sure how, if I'm doing that, it is an oral mutational inhibitor for a target, the incidence of a ESR mutation in the front line who are not exposed to AI is less than 5%. And the patients who have been exposed to AI for at least 6 months, the mutation rate increases to more than 40 to 50%. So basically, I take home two messages, that if I have to look at the ESR1 targeting pathway, the patient should have received at least 4 to 6 months of AIs. Then only the normal way of mutation is usually the predominant is the ESR pathway. In the front line who are not exposed to AI, the mutation pathway is only active in 5% of patients. That is one concern. So I would like to see one trial which will show a positive report on the upfront failed, not AI naive patient, is what I wanted to point out. Point number two, I would just like to add, rest I totally agree with Bharat that this field is getting crowded. I will look at the PIK3, and if PIK3 is not active as a target, then probably I will totally take that the oral SERT is something which I will take it on a Monday morning if it comes to my OPD. In that context, because the last question, I will just put PADA1 also should come into the context here. And I have my reservation. I know all of my colleagues are going gaga over a PADA1. I have 3-4 reservations over it. I know Bharat is a PADA1 guy. So my issues are 2-3 in PADA1 on that context. It is that you are doing a subclinical change of treatment, something like which we did with the CML thing, that there is a mutation which is growing, and before the hemat relapse happens, I'm going to change it. I have 2-3 concerns, and that could be the last because the time is less. The frequency of testing, is it practical? Because I do at baseline, I do after 1 month, and then every 2 months. And most of the patients fail after 1 year of a CDK. Means I'd be at least doing 8 to 12 marker testing, and that would add to the cost all. Number two, the OS data is not there. So should I change my treatment just on the subclinical data, on the mutational data? Number three, most important, which I felt, I don't know, this is never discussed when PADA1 is discussed. Post-progression in the arm which is a fulvestrant, the patient went on to receive a drug plus palbociclib again. So look at the PFS2 data. The drug CDK4/6 was again palbociclib. How many of us do not continue with the same CDK4/6 on progression? So I have my concerns with the PFS2 data, and that data, if you are continuing palbociclib on progression with the palbociclib, I am little skeptical that should I be taking PADA1 as it looks like. But as a concept, beautiful that you have a target. If you target it earlier, you will get a benefit. So I will brief it out by saying the HER2/neu positive data front line is nearly set as of now. As the data evolves, we can debate about it. But the second line is crowded. There are a lot of options. You need to get a PIK3. You need to probably now get a ESR1 mutation, and then probably sit down and then decide, till this drug is there, Elexatrand, I would still be comfortable with fulvestrant, or still be comfortable with chemotherapy if the treatment PFS was very short with the frontline hormone. I think chemotherapy should not go away out of our radar. If there is a particularly short PFS with a frontline AI and CDK4/6, I will be more inclined to go for a chemotherapy rather than a second line hormone therapy. That's my thought on this whole thing.
Perfect. Whatever sir said, more or less summarized it. PADA1, basically the concept is now at least, because the problem came is, if there is a ESR1 mutation, is fulvestrant better than AI? That is something that has been proven. Because the problem was with in before, if you remember your Pearl study, there were fulvestrant was used in that was there was advantage. Sophia, the concept came from Sophia study. In between, some studies probably did not give the same view, but this view basically the concept of fulvestrant being used in those with the ESR1 mutation, that is basically substantiated again. And technically, what sir said, every 2 monthly checking is impossible, and continuing palbociclib beyond progression, because PFS2 was only 3.5 months. Absolutely agreed. The only thing is, if you have a ESR1 mutation, one thing for sure is fulvestrant is better than AI. That is something that PADA1 beyond doubt proven it in a prospective study. Now what sir said, everything,
And Emerald proved that, Elexatrand is better than fulvestrant. So that's how we goes.
In any of the setting, that is what I wanted to stress. And one thing more is that fulvestrant is a single agent. What sir said is I even missed out. PIK3 mutation is there, I think so. You have to give the alpelisib, because single agent fulvestrant in a second line is the PFS in any of the thing is only less than 2 months. Probably that is what. So it is probably a weaker thing once you have given your CDK4/6 as a single line also. So I agree. Even I can give chemotherapy also. At least 2 months PFS. I think you can achieve it chemo also in those scenarios, sir.
Yeah. And lastly, before you end, probably the Pearl data should be discussed, although we can criticize the data. And the data of the second line CDK4/6 versus chemotherapy capecitabine and capecitabine just 1 hour, and it was proven to be similar or a little better.
Yes,
so I
and
think
these were early
that,
refractory patients.
Yeah. So I feel in that subset of patients, chemotherapy should never be forgotten, and that really works.
That is what I wanted to make a point. Pearl study.
Yes, I agree that Pearl data actually is an eye-opener for everyone, and we don't discuss Pearl too much in our clinical meetings, but I think we should discuss such studies also which have not really shown the benefit of CDK4/6 post one line of therapy. Right, so I think we come to the end of this discussion. We could have carried on and on, but then in the interest of time, I have enjoyed this discussion and learned a lot from this discussion, and I'm sure all the active participants have enjoyed it as much as I did. And I can assure you that both of you, my experts, that we will have you in the future meetings as well, because I have found this concept to be very enlightening for all of us. So I thank you, both of you, for staying with us this late in the evening. And thank you very much for your expert comments and inputs on the new trials which have come up. And we hope to see you again sometime in the next clinical meeting.
Just before you end, I will tell you, I just agreed because you are Bharat here, who I really admire, and Rajat, you have been.
I am your greatest fan. Absolutely no. Thousands fan club. I'll be the president.
And I can tell you, Rajat, it really gives me great pleasure to discuss live, and that really gives you and without discussion prior. That's what I want people who little are there, that we never discuss any of the questions which you asked, and that really gives you an impetus to study more. Thank you, Rajat, for considering me for this.
Agreed.
And thank you, and thank you, Rajat. I would like to thank you first for the opportunity which you gave to me. Thank you.
Thanks. Absolutely agreed with what said. Thank you for the opportunity.
It is all ours, and that too at a very short notice. I know for both of you. Thank you so much, sir. Thank you. Have a great evening. Thank you. Yeah. So we move ahead now, and we come to the last part of our talk, which is the talk on the role of denosumab in solid malignancies. And to give this talk, we have with us Dr. Pankaj Goyal, sir. Sir, good evening.
Hi, good evening. How are you?
I'm good, sir. I hope you are doing well, and thank you for bearing with us. I know we are running late. So
no, but this was an interesting discussion. Dr. Sahu and sir are really interesting to. It was a learning experience for us to listen to them. It was great.
You know, Pankaj को देख के हमेशा लगता है ना, relax रहता है यार. See the way he's so cool, यार. I really admire.
Patience कम होते हैं ना सर हमारे पास.
चल बाद में. चलो, take care. All of you take care.
ठीक है. Okay.
Okay, sir. Thank you. So Dr. Pankaj is a senior consultant in the Department of Medical Oncology at Rajiv Gandhi Cancer Institute, and he will tell us about the bone modifying agents in solid malignancies. Over to you.
Yeah, thank you, Rajat. It was an amazing CME which we have conducted, and most of the recent advancements have been, I should say, dissected out as per the fine details are concerned. So just last topic, and I think will be very few people who will be attending this. So maybe we can start that Mayor Merit and I will be talking about bone modifying agents. So, so we know that denosumab is a human monoclonal antibody, and after having all this EMERALD study and all this TDX and so many drugs, I think this will be a bit outdated, but still, we know that's a rank ligand which works by preventing the development of osteoclasts, which are cells that break down bone. And this is the way these drugs work. We are very well aware of that we have interaction of these osteoblasts, which make tumor cells produce factors that stimulates osteoblasts to secrete rank ligands, which interact with the osteoclast. And there we have this bone resorption. So we have these rank ligands who can stop this interaction and thereby
reduce the osteoporosis or tackle the bone metastases which are there, which are causing fractures at times. So burden of bone disease cannot be underestimated. 7 out of 10 patients with breast cancer have these bone metastasis. Same is the case with metastatic prostate cancer, metastatic lung cancer. 4 out of 10 do have these bone metastasis. And in the it was seen that bone metastasis they had more complications of these bone mets like fracture or something. So it was seen that in the patients who had these metastasis, if they are put on a placebo, they have 64% of chances of having some bone-related event. And in prostate cancer, around half of the patients will have some bone-related complications. And nearly all the patients who are having multiple myeloma, we know have chances of having these bone involvement, almost 9 out of 10. And multiple myeloma weakens bone and puts patients at risk for fractures and other bone complications in 60% of the cases. And we know that bone marrow is the basic playground of these cancer cells, and thereby leads to a lot of burden on these bone. And many patients with solid tumors are at immediate risk of bone complications. Within 1 month, 1 out of 4 will have some sort of complication. And with 3 months, 1 out of 3 will have some bone-related complications. So we know that the skeletal-related events are there, and they can require multiple treatments. Maybe they will require a surgical approach, the way we have to do some reduction, or we have to put some nail or something. And many of these will also need radiation. So these are known as skeletal-related events, very much aware of, but not just a simple fracture. If it is at a crucial site, then it probably can cause hemiplegia also. So we have to be very careful about that. And spinal cord compression is seen in 20 to 30% of patients with breast cancer, 15% with lung, and 10 to 15 with prostate cancer. So previously, we used to feel that probably zoledronic acid and denosumab, efficacy-wise, they were appearing to be same. However, denosumab was always known to be a safer agent. But now we have these studies where denosumab has been proven to be better than zoledronic acid, and that too in randomized phase 3 trials. So these are the various trials in which we have seen that the denosumab, when compared with zoledronic acid, in a patient with prostate cancer or patient with breast cancer or multiple myeloma, in all of these we have randomized study to say so. So this was one of the trial in which these patients who commonly have these bone metastases like breast, prostate, or other solid tumors or multiple myeloma were also included, and they were randomized to either denosumab, and others were given the zoledronic acid, and they were also given supplemental calcium and vitamin D. So time to first on-study skeletal-related event was analyzed. It was a non-inferiority study. Secondary endpoints was the time to first on-study SRE and time to first and subsequent on-study SRE. So this was the analysis. Denosumab, we see that the median time for first bone complication was 27.7 months as compared to 20 months in the patients who were on zoledronic acid. So there was improvement of 7 months, p-value being very significant, hazard ratio 0.83. And this reduction in the bone complication was not a temporary phenomena. As we can see, it's from beginning to the end, from 3 months to 27 months, there's a wide gap between both of these graphs. And consistently, we can see that chances of having bone-related events is to the tune of 12 to 16%. So superior efficacy has been seen across all the solid tumors. So if you see in the patients with the breast cancer, or we see in multiple myeloma, more or less there is 18% risk reduction of having bone-related events. So this works across irrespective of the primary, whether breast, prostate, or multiple myeloma. Skeletal-related events, as we choose a better event, there is a 20% additional, you can say, safety. As we can see, when there is no bisphosphonate use, then there is 64% risk at 2 years. Usage of pyridoxine decreases by 20%. Usage of zoledronic acid again reduces by 20%. And if denosumab is being used, then that's the best way we have decrease in the chances of bone mets, decrease from 64% to just 27%. So efficacy-wise, we know that risk reduction is good to the tune of 18 to 24% in all these cancers: breast cancer, prostate cancer, multiple myeloma, and other solid tumors. And that is why now in NCCN, as we see that bone-directed therapy Denosumab has attained a category 1 recommendation and also have been documented as a preferred agent as compared to zoledronic acid, though that is also an option. With that, I'll conclude, and thanks a lot for the patient's hearing, and it was great. Thank you.
Thank you, sir. Thank you for the nice presentation. So, how many osteonecrosis of jaw have you seen with denosumab?
Uh, See, most of the patients used to get zoledronic acid, but now more and more people are actually getting denosumab also because of the generics which have come into the market. But honestly speaking, I do not see too much of these patients with these osteonecrosis jaw. Looks more of a theory. I have seen 2 or 3 patients who were on zoledronic acid, and I do not remember any patient on this denosumab who presented with such complication.
Okay, and although the theory says that the incidence of osteonecrosis of jaw is the same for both
Same, yeah, theory
zoledronic
says so.
and
But then
denosumab.
because more patients have been on zoledronic acid, that's why probably we have seen 1 or 2 patients. So in the time to come, maybe we'll see. But actually, we are also defensive that we usually have started testing these people that we send them to the dental surgeon to have an analysis, and then we go around. And if there is some problem, then we stop early, or maybe from monthly to we have switched out to 3 monthly. So maybe that's why the chances of the having this osteonecrosis have come down as compared to the previous times when they were used in a monthly fashion.
Okay, and do you always make it a point in your practice to send these patients regularly to the dental experts to have their oral hygiene checked?
Yeah, now this have become institutional protocol. Thanks to the big bosses.
Okay, okay, okay.
Yeah.
So, right, right. Thank you
Okay.
so much for being here. Thank you very much.
Thank you. Thank you. Thank you, Rajat. Good night.
Thank you. Good night.
Very good meeting. Thank you.
So with this, we come to the end of our 2-day webinar on the updates of SABCS 2021. In this webinar, over the last 2 days, including today, we have learned a lot about how things have evolved, and they promise to evolve in the field of treatment of breast cancer. It always is very exciting to learn these new updates so that we as clinicians can pass on more and more treatment updates to our patients today and in times to come. It is only very apt that today, on the day of World Cancer Day, which is always dedicated to the cancer survivors, we as clinicians can learn more and can pass on the benefit of newer updates which are coming in the field of breast cancer, which is one of the most common cancers in women in India and abroad, to our patients, so that the survival of our patients can increase. I have enjoyed a lot, and I'm sure all the attendees have also learned a lot. I would like to thank the pharma companies who have been a part of this journey and have made this scientific program possible. Last but not the least, I would like to thank all my attendees, all my expert panelists, the speakers, moderators, for being a part of this discussion and sharing your important thoughts on it. I would like to thank Mr. Tarun Mathur and his team, who have painstakingly taken efforts to arrange and organize this event in a wonderful fashion. With this, I would like to come to and conclude this session, and I would thank everyone for being a part of this event. Good night to all of you.
So thank you so much. Thank you so much, everyone. Thank you, Dr. Rajas sir, on behalf of the entire organizing team, my colleagues, Aram and Palak and Ekta. So thank you so very much for giving this opportunity. Good night, stay blessed, and see you next time. Thank you so much. We close the meeting now.